morning, everybody. Thank you for coming today, taking time out of your Saturday to come to the plenary session of Pro Medicina 2025. Um, so today, your coordinators are myself, Valerie Sauru, and also Antonique Nera, my colleague over here. We just have a little bit of change in the schedule. So before we dive into the introduction presentation, we're just going to introduce one of the participants for today, just from time constraints. So if you don't mind, I'd like to call on Rami Altabush to please present his presentation for us. He won first place in the basic science session 2 days ago.
Okay. Hello. Good morning. My name is Rami Altabouche, and I'm a fifth-year medical student present here to present to you my research paper titled The Role of Alpha-2 Integrin in the Cardiac Fibroblast Extracellular Matrix Remodeling. Cardiovascular problems have been the leading cause of death in the world. According to the WHO, every year we're losing at least 18 million lives, not only in the world, but also in Poland. If we look at the numbers of patients that had heart failure in 2019, it reached almost 1 million patients. And if we look even closer to the contribution of heart failure to the percentages of death in the Polish population, we can see that it nearly doubled in 2021, and it reached 30% of people who died of heart failure. One possible explanation of heart failure is cardiac fibrosis. Whether seen as reactive or maladaptive, cardiac fibrosis is the main contributor to heart failure. How to explain cardiac fibrosis? So fibroblasts and myofibroblasts are the key modulators of fibrosis. They bind and activate the accumulation of collagen in the ECM. Several factors activate fibroblasts, such as TNF-alpha, IL-1, 4, 6, IL-10, and many more. But the most powerful profibrotic factor has been proven to be TGF-beta1, according to the literature. There are other modulators as well who can activate the collagen and bind to collagen directly, such as these glycoprotein family of heterodimeric glycoproteins who can span the plasma membrane. They bind to the cytoskeleton and can bind to collagen in the ECM and can modulate it in different ways. That's why we postulated that there might be some connection between alpha-2 beta-1 and decorin. But what is decorin? Decorin is a proteoglycan. Through its 42 kilodalton protein core, can bind to TGF-beta1, the factor that I mentioned earlier, and can block it from activating fibroblasts, thus inhibiting extracellular collagen accumulation. That's why we wanted to see the correlation and the relationship between alpha-2 beta-1, collagen, decorin, and glycosaminoglycans, who are the main factors of that constitutes the ECM. The main of our study is to evaluate the regulatory effects of extracellular collagen first, and then the alpha-2 integrin on the ECM accumulation, more specifically on collagen, decorin, and glycosaminoglycans. That's why we made big experimental models. The first one, we used two big media. So the first media, we used immortalized heart fibroblasts in collagen-rich media and in collagen-poor media. And we measured glycosaminoglycans, decorin, and collagen. The second set of experiments were involving the alpha-2 beta-1 receptor. We used two techniques to modulate or inhibit alpha-2 beta-1. The first technique was to see the effect of the inhibition of alpha-2 beta-1 using TCI-15, which is a potent alpha-2 beta-1 inhibitor. How we proceeded, we used the control group, we used TCI-15 in two different concentrations. The second one was a more specific using silencing technique. So we silenced the alpha-2 beta-1 receptor indirectly. So we silenced the alpha-2 subunit, and by definition, by silencing the alpha-2 subunit, we're also silencing alpha-2 beta-1 because this is the only possible combination. So we used the control group, non-targeting RNA, and siRNA applied cells. The effectiveness of the silencing was measured using flow cytometry and also by RT-PCR to make sure that we properly inhibited so much for your question. So basically, we are already starting with this experiment in vivo models, because in vitro models are not always the exact same thing in the in vivo models, because you know there are many other factors. And this is, I try to simplify it as much as possible to just show the correlation between them. So what we are doing, we are inducing fibrosis in mice models, and we are trying to see if there is any effect on in vivo models, and we are starting to proceed with the same protocol. So if we are able to see that these are also consistent, we are going to expand the experiment and move to the to actual in vivo models. And because in vitro models, as I said, they have some limitations. So this is what we're gonna do right now. Yes. Yes. No, we are going to induce using isopreterenol, which is a beta-1 activator agonist. And by activating certain concentrations, more specifically 250 milligram, can induce cardiac fibrosis. Even if we go higher, we can induce even heart failure. So we started with this, with isopreterenol. We injected them. We had two control groups. We had one control group where we just injected saline solution, and the ones were treated with isopreterenol. So we are inducing the fibrosis, then collecting the hearts, and checking for these patterns. Thank you so much. Of course. Yes, of course we are. This is one of the limitations of the in vitro model. That's why I was saying that we know that these are present, like these limitations are present, but we are not afraid because they should correlate in a certain way with our results. Maybe, yes, because also if you can notice, one of the conclusion here was alpha-2 beta-1 was not correlated with collagen, although alpha-2 beta-1 has been proven to bind to collagen. So we want to see if maybe in vivo models it might be different. So that does not really exclude our conclusions, but maybe it can tell us that there are other mechanisms that are involved in the collagen accumulation. And we also started another set of experiments with alpha-1 beta-1, because as you know, these are the only four alpha-2 integrins. So we wanted to see also if there is any impact or not with the other ones. Thank you so much.
Questions? 2 minutes left. More questions? Any questions from the audience? Okay, if that's it then.
Thank you so much. Thank you.
Ladies and gentlemen, dear jury members, tutors, dear colleagues, it is our pleasure to welcome everyone at the 63rd Polish and 21st International Students' Medical Conference, JUVENES Pro Medicina 2025. We would like to start and open the plenary session. My name is Antoni Knera, and together with Valerii Ozovaru, we are the coordinators of this session. To begin, we would like to give the floor to the President of the 21st International JUVENES Pro Medicina Conference, Wojciech Jankowski.
Okay, so dear guests, dear participants and speakers, welcome to the plenary session of the JUVENES Pro Medicina Conference. We are very happy to have you here today. These events bring together young people who are passionate about medicine and science. It's great to see you, so many students, PhD candidates, and researchers from different places and backgrounds. The plenary session is a special part of the conference. It's time when we can learn from each other, share new ideas, and think about the future of the medicines together. I hope you enjoyed the talks, meet the new people, and feel inspired. Let this conference be a place where knowledge grows and the new friendships begin. With that, I'm happy to officially open the plenary session of JUVENES Pro Medicine. Thank you.
Thank you, Wojtek. Next, we would like to invite Professor Eva Severynek, Student Scientific Society Curator, to take the floor.
Thank you very much. Dear students, the guests, the jury, I am pleased to welcome you on the plenary session. It is a special session, Wojtek told, that is a session dedicated to people who were received the first award in the thematic sessions. And it is competition. And of course, because it's competition, it will be also first, second, and the third award. Also financial, but this I think will be later. This conference, as told before our chairman of this session, it is 63 in Polish and 23rd international. So we have very long tradition. And of course, this conference is organized every year by Student Scientific Society, also this year. And on this place, I would like to thank you very much, the organizing committee of this conference, especially Wojtek Jankowski, Ania Savina, Kinga Stanek, but also others, Mikołaj, Marcin, Julia, Ola, and many, many others, assistants and coordinators of sessions. So it is many people who were involved in preparation of this Congress. And JUVENES Pro Medicina gives possibility not only to present the research of research, but also to have very good friendship, which lasts very long time. I am the case of this because some of my friends I met during my work in Student Scientific Society and during the first conferences which I attended, and still we are in touch. So I hope that this conference will be good for you and you will have good memories, and hope that you will attend also the next conferences. This conference consists of many sessions, and I can tell that it is 15 thematic sessions. It is 9 case study sessions, but during these 3 days, each day was many workshops. And from this place, I would like to thank you very much, the students, tutors of student scientific clubs, for preparation these workshops. I know that students are very happy because some of them are very interested in some aspects of our research during the study. So thank you very much also our jury and all coordinators of sessions, because these 3 days were very busy. And hope that we will meet next year, and I wish you the next further success on the area of research. Thank you very much.
Thank you so much, Professor, for your speech. We would also like to remind you that the special lecture will take place at 11:30. This lecture will explore the groundbreaking shift in surgery, the transition from traditional laparoscopic techniques to advanced robotic surgery. Professor Benedetto Ielpo, surgeon from the Hospital del Mar in Barcelona, will discuss the technical aspects, challenges, and benefits of using robotic systems in surgical procedures. Now it's time to announce the results of our Instagram contest. The winner is Mateusz Mich. Firstly, we would like to thank the Minister of Education and Science for a program called Doskonała Nauka, which is co-financed in this conference. Organizers, Student Scientific Society, and honorary patronages, Medical University in Łódź, NFZ, Students Government of Medical University in Łódź, IFMSA, oddział Łódź, doktoranci UMED. Some more coronary patronages. We would like to thank also our patronages and award sponsors in the plenary session. The sponsors of main prizes are the Foundation of Medical University of Łódź, Więcej niż lek, Medical Publishing House, PZWL, Więcej Store. And it is an honor to welcome the jury of the plenary session. Dr. Karolina Henryka Czarnecka-Hrebelska, Dr. Katarzyna Kalit, Dr. Katarzyna Góralska, Dr. Angelika Długosz-Pokorska. Thank you so much for your appearance today.
Thanks so much, jurors, and thanks to the audience as well. Just a few regulations that we have. We'd just like to remind you of some regulations. So in case of absence of any ushers at the scheduled time of their presentation, the presentation will be shifted to the end of the scientific session. If the session extends beyond the planned schedule of the conference, the coordinator of the scientific session has the right to cancel the shifted presentations. The presentation time is 10 minutes and 3 minutes for discussion. We will have a timer. We keep track of all the presentations as well. The time of the presentations will be counted by us. Exceeding the time of presentation results in getting -5 points. In case of exceeding the time by more than 5 minutes, the coordinator can pause the presentation. In this case, discussion does not take place. Tutors and co-authors are not allowed to participate in the discussion. Participation of a tutor or a co-author would result in deduction of 5 points. Presentations will be judged by the jury on a scale of 0 to 5 in the following categories: structure of the presentation, aim and background of the presentation, correct selection of the methodology, presentation of the results, its discussion, and the correct drawing of conclusions, correct answer to the questions, general performance of the presenter. In a situation when 2 or more presentations have the same final score, the chairman of the jury has to cast and vote. So during the break, I would please advise the jurors to pick a chairman, just to dissolve any dispute if there is any. The sponsor of the main prizes in the plenary session is FUMED, the Foundation of Medical University of Rouge. The announcement of the results will take place after the deliberations of the jury, which will take place right after the end of the session. These are the order of the presentations. We already had the first presentation in Basic Science by Rami Altabush, and we have 13 more. I think the second and the third are not going to be present today, unfortunately, but I think that's already been corrected on the forms that you have, which you're...
They will be presented. Yeah.
You can ask, perfect, okay. Okay, you can, yes. Now, so we have PhD Clinical Natalia. I'm not going to try with the last names because I don't think you can probably say mine, so I will try my best. Plushenik Kuriska. Mine is also very hard. With the PhD Molecular, Blanca Silvan Ross. With Psychiatry and Psychology, Carolina Koshik. Internal Medicine, we have Alexandra Roscoe. Pediatrics, we have Barbara Pernak. Dermatology, we have Arthur Zezrash. Oncology, we have Jacob Szewinski. Surgery and Transplantology, Natalia Anna Cook. Physiotherapy and Orthopedics, we have Wojciech Boszensky. Pharmacy, we have Zofia Plonkowska. Dentistry, we have Julia Maszczyk. Gynecology, we have Maya Sheniaszowska. Prenatal Cardiology, we have Monica Reszka. Cardiology and Cardiosurgery, we have Katarzyna Skorupska. And that's my 1 year of Polish put to the test. Okay. And now it's finally time to start the presentations. We already had the first presenter, and I would like to call on the second presenter, please. PhD Clinical Natalia Ploshnik-Koryshka, please. Thank you.
Good morning, everyone, dear jury, dear colleagues. Thank you for having me. I really appreciate the opportunity to share my results. Today, I would like to share the results of my research project. It's entitled Exploring Manual Therapy in the Management of Irritable Bowel Syndrome in Adults. So to introduce a little bit myself, maybe, I'm Natalia Płóciennik-Korycka, and I am a physiotherapist and PhD student in the International Doctoral School at Medical University of Łódź. And this scoping review we prepared in the international team. Professor Magdalena Wrzesińska from the Department of Psychosocial Rehabilitation and Professor Paolo Contu are my supervisors. So, irritable bowel syndrome is a chronic gastrointestinal disorder which significantly affects people's quality of life, but also their activities of daily living. And the most common symptoms are abdominal pain, bloating, diarrhea, constipation. And because of people persistent experience these symptoms, they are looking for another treatment than pharmacotherapy, and one of these treatments could be a manual therapy. Manual therapy is a hands-on approach offered by mainly physiotherapists, but also osteopaths and chiropractors. The aim of the study is identifying and mapping the existing body of evidence on the effects of various manual treatments on biopsychosocial functioning, well-being, and quality of life of people with IBS. So for this scoping review, we followed very strict guidelines from the PRISMA Scoping Review and Joanna Briggs Institute. We used the PCC framework to develop and define clear objectives and eligibility criteria. And next, for transparency, we registered the protocol of the study on the Open Science Framework website, so you can get the access to the protocol through the VR code. So we included studies with adult populations diagnosed with IBS that investigated manual approach to treatment this disorder. And the following types of sources were included. Randomized control trials, non-RCTs, before-after studies, systematic reviews, meta-analysis, and literature reviews. So from the 730 records, finally we included 30 studies published between 1975 and 2024 among 14 countries. There were 9 trials and 21 reviews. And the following types of manual treatment were explored. Osteopathic manipulative treatment, acupuncture, acupressure, reflexotherapy, tuina, and traditional Chinese spinal orthopedic manipulation. So, as you can see, all of the manual approaches have some positive impact on particular areas. And for example, for biological outcomes, we have reduction in diarrhea, bloating, pain, discomfort, and even in one of the Chinese approach, the Chinese approach is more effective than pharmacotherapy. For psychological outcomes, the results are more mixed. But we have also the reduction in stress scores, improvement in perceived tiredness, and also in depression. The social outcomes are largely unexplored, and this reveals a huge gap in the research. And for quality of and well-being, all of the manual treatment have some positive impact, both long and short term. Only despite the acupressure and Chinese manipulation, because it was not specifically mentioned in the studies. So this presentation summarizes various manual techniques and gives us a broad overview how these therapies affect not only physical but also psychological, and I hope in the future the social area of people functioning. So give us the perspective broad and very holistic. However, it's important to know that the evidence comes from small and very low quality of the studies. And the results are really mixed. So some studies show positive effects, while the others only minimal improvements. Another key issue is the lack of standardized questionnaires and high variability of study designs. So it's very difficult to draw clear conclusions about the overall improvement of those therapies. So, in summary, one major gap in current research is lack of studies on how these therapies affect patients' social functioning. It's important for healthcare providers to recognize the potential of the manual therapies and to include them in the treatment plans, of course, based on solid and high-quality evidence. Future studies should focus on patient-centered approach to better address the complex needs of patients with IBS. And I would like to emphasize that manual managing of IBS, it's a kind of thinking outside the box. That's great, and I truly love it. And manual therapy could be one of the solutions, but only if we keep asking good research questions and be critical about the answers. If I have piqued your interest about the topic, and you want to delve deeper into the outcomes of the report, so you can scan the QR code and find out more. So thank you for your attention.
Thank you so much, Natalia. Any questions from the jurors? We have 6 minutes, so loads of time.
Okay, so thank you for your question. So for me, this approach, it's not the first step to treat IBS. So first step always is a pharmacotherapy for this disorder. So I hope that medical doctors could be more aware of the potential of the manual treatment and gives the patient a clue, and it's okay that there is the manual therapy or there is the physiotherapist or osteopaths. You can go there and maybe it will be helpful for you. So now we don't know if it will be for 100%. We don't have the sure. But okay, you can try and maybe it will be helpful for you. So yeah, it's kind of recommendation. It's not the way of treatment.
Any other questions?
Very practical question. Which of this procedure you would recommend?
So next week and next month, I will be the osteopath. So for me and from my bottom of my heart, I really recommend the osteopathic manipulative treatment because it's a visceral approach. So we are working on the visceral fascia, and we can decrease the tension and pain in the abdominal area. So yes, I truly recommend it, and I also experienced it. So yes, I can tell you, not based on the studies, but yes, it's really helpful. So I really recommend going to the osteopaths and physiotherapists who work visceral, and yeah, that could be very helpful for you. Yeah, so it's not explore the mechanism of working the acupressure in Chinese medicine. I'm also not specialist in reflexology, acupuncture, acupressure, so I don't really know, but it's a kind of manual treatment, and physiotherapists, chiropractors use it. So I had to put the presentation, but I don't really work like that, so I don't really know how it works.
Any other questions?
Yes, there is.
Any questions? Yes.
Yes. Yes, of course. So the adverse effects were assessed, mainly all of the studies, and there was no adverse effect. So yeah, it's really promising.
Any questions? 2 minutes?
Thank you so much.
for coming. Thank you. And now I'd like to call on Blanca Sylvan Ross for a presentation. Blanca won first place in PhD molecular category.
Okay, so good morning, everyone. My name is Blanca Silvan Ros, and thank you for the opportunity of presenting today. So, I am a PhD student in a process of a co-tutel agreement between Universidad de Juan Carlos in Spain and Medical University of Mons. So today I'm going to talk about the impact of a pro-inflammatory cocktail stimulating COVID-19-like molecular pathways on gastrointestinal motility in a preclinical model in aged rats. So, sepsis is a widespread inflammatory response to infection that in critical cases, like for example severe COVID-19, the cytokine storm can trigger a multi-organ dysfunction. So, one of the first systems to be affected, but not the only one, it is the one that we are going to focus today, it is the gastrointestinal tract, showing a dysregulated brain-gut axis. Why? Because this sepsis can disrupt gut motility, also can impair fluid balance, leading to symptoms such as vomiting, diarrhea, or dehydration, and also increased visceral pain sensitivity. So for all of these reasons, sepsis is one of the leading causes of hospitalization worldwide. So as we can see in this graphic, despite all of the investigation that we have nowadays about sepsis, mortality remains high. And that's why preclinical models are essential to advance in our understanding of sepsis. So in our lab, in Universidad of Juan Carlos, we developed a preclinical model that mimics the cytokine storm associated with severe COVID-19. So we use a pro-inflammatory cocktail that contains some substances that targeted the main molecular pathways involved in this cytokine storm. So we use LPS that internalizes the ACE2 receptors, also imiquimod that it is an agonist of the toll-like receptor 7, and finally we want to mimic also that damage that the virus made into the body, so we also use ATP. When we administer this cocktail into the young male rats, we find some acute gastrointestinal dysmotility, but we didn't find any sequel. So with this in mind, what happens when the AIDS become a factor? As we saw in the COVID-19 pandemic, the AIDS become a key role in the disease severity. So, and also, as we can see here in this global study, the relative risk of death is increased progressively with AIDS. And if we focus on patients over 75 years old, we can see that this risk is really high. So, with all of this, our aim of today is to evaluate the acute impact of the cytokine storm induced by this pro-inflammatory cocktail on gastrointestinal transit and the possible sequel in aged rats. So, for study this gastrointestinal transit, we are going to use some radiographic methods. We use male Wistar rats with 20-24 months old, and we administer either the vehicle or the cocktail. So I want to highlight that the doses that we use in the young rats were higher, because when we use these doses to the aged rats, we find a really high mortality, and we decided to decrease the LPS doses so we can assess the functional experiments. So, in the first week of these radiographic sessions, in the first time point, we administer intragastrically the barium. This barium is the contrast that permits us to see the organs in the X-rays. Also, we administer intraperitoneally the LPS. So then we finalize to put all of the cocktail, and in each time point that we can see in the screen, we make an X-ray until the final 24 hours. So here we will see the acute effect of this cocktail. Also, I want to show you some examples of these X-rays that we assess and how the organs are seen with these contrasts. So these radiographic sessions are used to analyze the transit in the stomach, small intestine, cecum, and colon. Finally, we repeat this experiment at each time point so we can see also the sequel effect of this cocktail. So if we move to the results, first I want to show you the semi-quantitative analysis. This analysis permits us to see how the barium is advancing through the gastrointestinal transit. So as we can see here, we will find 4 different graphics with 4 different organs: stomach, small intestine, cecum, and colon. So how this semi-quantitative analysis works? We use a score with different points that we are put in every organ, and we can see then in all of the time points how the barium is advancing through the gastrointestinal tract. So as we can see in the black lines, we will find how the controls motility is working. And if we focus on the red ones that are the treated animals, we will find that it is a delayed gastrointestinal transit. It is also suggesting a gastroparesis and a paralytic ileus. So if we move to the sequel effect, we can see that these effects normalize, and we didn't see any difference between the control group and the treated group. So these results are similar to those that we saw on the young animals. So for the maximum organ size, for example, in the stomach, we can see that there is no difference between the control animals and the size of the treated animals. But if we move to the cecum, we can see that this is smaller in the treated ones than in the control ones. I want to highlight also that the cecum is a really big organ in the rats. And when we see the sequel effect of the cocktail, this difference of size normalized, and we didn't see also any difference between both groups in any of the organ sites. So finally, for the maximum contrast density, that it is how strong we see this barium in the X-rays, either in the acute effect or in the sequel effect, we didn't see any response or any difference between these groups. So, for concluding, the pro-inflammatory cocktail use acutely delayed gastrointestinal transit in aged rats without sequel. This finding closely mirrors those previously observed in young animals treated with the higher doses at the same cocktail, supporting the model's consistency across age groups. So, this developed preclinical model is simple, economical, and rapid, and will facilitate the search for new strategies to prevent or treat the severe effects of the cytokine storm and sepsis associated with SARS-CoV-2 and other infections. So finally, I want to thank my co-authors. Also, I want to thank my research group from Spain, on Universidad Juan Carlos that it is called NewAd. Also, I want to thank the founding sources of this project, and of course, I want to thank you for all of your attention and for being here today.
Any questions from the jurors? No? That is
So yeah, we see if we compare the graphics of the young rats and the aged rats, we find a difference between the controls. So yes, it is delayed. I don't know if this have another effect, but we know that the aged rats have a delayed gastrointestinal transit. But it's very different with the treated ones. I think we have a clear effect in the cocktail compared with the control ones. So they are the same rats. So.
This leads to my second question, whether the delayed passage of the material in the intestines can also lead to the stronger effect of the stronger inflammation effect in case of infection.
We are now seeing, compared with both of them, we see the same delay in the young rats and in the aged rats. Maybe it's because we have a lower doses of the LPs. Maybe if we can make the higher doses, we will find really big differences. But we didn't have the chance. So yeah, more or less they have the same effect. Yeah. Thank you.
Any questions? Any more? No? Thanks, Blanca.
Thank you.
And now I'd like to call on Carolina Koshik. Carolina is presenting under Psychiatry and Psychology.
Dear Commission members, esteemed guests, my name is Karolina Kozik. I am a third-year student of dietetics at the Medical University of Silesia in Katowice. It is my pleasure to present to you a study entitled The Risk of Eating Disorders Among Track and Field Athletes. Eating disorders, such as anorexia, bulimia, and binge eating disorders, seriously impair physical and psychological health. Due to the specific demands of the sports environment, track and field athletes represent a group at increased risk of developing eating disorders. Some track and field disciplines are classified as leanness-dependent sports, which, according to research, is connected with higher risk of developing eating disorders. Despite many studies on eating disorders risk among athletes, there is a limited amount of research specifically focusing on Polish track and field athletes. For this reason, a study was conducted to assess the prevalence of eating disorders risk among Polish track and field athletes. The research tool of a cross-sectional study was a survey questionnaire composed of the following elements: dating attitude tests in Polish adaptation by Professor Blitek, Matera and Rogoza, used to assess the risk of developing eating disorders, the Dusseldorf orthorexia scale, and original validated questions developed by the author of the study. Athletes were personally invited to complete the questionnaire in person during 16 different athletic events held across Poland the previous summer. Following this initial contact, the questionnaire was sent to them for submission. Statistical analysis included descriptive statistics, chi-squared tests, gammas and Euler's correlation coefficients. A total of 1,008 Polish track and field athletes participated in the study. The inclusion criteria involved membership in a sports club affiliated with the Polish Athletic Federation and being in the age category of at least under 16. In line with the classification commonly used in the existing research, the disciplines were classified as lineage dependent, such as distance running and jumps, and non-lineage dependent, such as throws and sprints. Athletes were also analyzed according to their age category, athletic level, and training experience. The mean age of the participants was 18.87 years, and the mean length of training experience was 5 years. Most athletes were classified as medium-level competitors based on their sports class, although the sample also included athletes at the elite level. Moving on to the results. 14.5%, 146 athletes were at risk of developing eating disorders. In line, the percentage of athletes at risk was higher among those training lineage-dependent sports, 15.5%. However, this result did not reach statistical significance. In the studied group, 9.2%, 93 athletes were treated for eating disorders. No statistically significant differences in the risk of developing eating disorders were identified in relation to age category, training experience, or athletic level of the studied athletes. The occurrence of binge eating episodes involving loss of control over the amount of food consumed once a week or more frequently was reported by 14.6%, 147 athletes. Comparing body shape to bodies of other athletes and feeling ashamed as a result was reported by 53.5%, 539 athletes. Dissatisfaction with body appearance was declared by 44.3%, 446 athletes, which was significantly and strongly connected to higher risk of developing eating disorders. 39.6%, 399 athletes declared that their sense of self-esteem depended on their body weight. Among those, the risk of developing eating disorders was also significantly and strongly higher. 18.8% athletes, 189, think that they would not feel the need to reduce body weight if they were not training, suggesting that for some athletes, the pressure to reduce body weight stems only from being an athlete. In line with the study's aim, there are two main conclusions. The prevalence of developing eating disorders was, the risk of developing eating disorders was prevalent among 14.5%, 146 Polish track and field athletes. No statistically significant differences in the risk of developing eating disorders were observed between the lineage-dependent and non-lineage-dependent track and field disciplines. Thank you for your attention. I will be happy to answer any questions.
Any questions from the jurors?
I've got a question about the gender structure, because according to information, it was about 75% of women and much more or less males, yes? And could you tell me, is it because of more females they are active, or just they are better responders for such
Yes, I agree, because worldwide the prevalence of eating disorders is 2 times higher among women. So the higher percentage of women could affect the results. This may be the reason of the 2 things that you said. That one, there is a little bit more girls in the track and field, but the girls are also better respondents. So this is the factors. I also, interestingly, I conduct other study where they are as many males and the females, and the results are the prevalence of eating disorder risk is at 18.5%, so higher. So that's the other study, but the prevalence is even higher when they are more males. Can you?
Why this line when sports has such results?
Yes, because where the sport is require leanness, so this is body dependent. So the athletes have to reduce body weight very often, also periodically. So that's just the result, the outcome of the sports competition really depends on the body weight. So that's a lot of pressure for athletes, especially young athletes. Yes, I would say more like the pressure to reduce body weight.
Is there, if there was any difference between the body weight or BMI of the analyzed groups?
Yes, because that's according to the disciplines. Because we have every track and field disciplines, so the difference between the sprinters and, for example, throwers were significant. The BMIs were analyzed, but that's going to be on the publication, because there was a little bit of problem, because we have participants under 18 and below 18, so we have to analyze them separately.
Have you thought about other measures than BMI because the pressure to reduce the weight or the pressure to stay in weight is also related with the fact that someone thinks about himself or herself that weight too much, but that has too much fatty tissue. So one of the way of analyzing this is analyzing BMI, but there are some other measures like the circumference of the hips or the waist to analyze the differences, to analyze the potential development of not obesity, but to measure the probability of developing the obesity of too much fatty tissue. And the question is whether have you considered adding some elements to your study to analyze this?
Yes, so this is the first study. I would extend that one. Yes, that's a great idea. For example, using the BAI method, so we can analyze the whole body structure. But that would be that's a great extension. But yes, this is just the first study in this field. But yes, of course, I would say I would also want to add the control group to this study. Yes. Thank you.
Maybe I missed this information, but did you have any question about the results? I mean, if eating disorders affect the response results?
I had many questions. So due to the time limitation, I didn't perform here all of the results. But yes, there were questions about that, about the effect on diet on their performers, of the pressure from the trainer. That were my validated questions. But also we can assess this more objectively because I have the athletic level, which was here. Based on the sports class, they were classified athletic levels. So I can measure this with the risk of eating disorders.
Thank you, Carolina.
Thank you. Thanks.
And now I'd like to call on Alexandra Roscoe, presenting in internal medicine.
Good morning, I'm Alexandra Mieszko, and I'm going to talk about the stem cell secretome as a cell-free modulator of type 2 low inflammation in experimental asthma. And to introduce you to my subject, I'm going to talk about the history a little. So we are working on understanding MSC's mechanisms of their immunosuppression for over 30 years, and yet today we have only one therapy registered using their potential, and it's not even in asthma. So in our research we used MSCs derived from adipose tissue of abdominoplasty patients, so from medical trash in fact, and we check them for characteristic MSCs markers such as CD73, CD90, CD105, and we also examine their ability to proliferate to adipocytes, osteocytes, and chondrocytes. We did also the PBMCs experiment to examine their immunosuppressive properties. So we can see that with the increasing ratio of MSCs, the ability of lymphocytes to proliferate decreased. We also did a mice model of T2 low inflammation. So black 6 mice had the inflammation induced with house dust mite extract 100 micrograms of extract induced administered intranasally on 5 consecutive days 2 times, and on day 6th we administered mice with MSCs as a treatment, and on day 15th we ended the experiment with collecting the tissues. And on histological stainings we can see the severe inflammation of lung tissue in only HDM group, and on the treated group we can see that inflammation reduced visibly. On flow cytometry results we can see that the frequency of interferon gamma secreting cells decreased for treated group, and the frequency of interleukin 10 secreting cells increased for treated group. But why do we have only one therapy registered if the immunosuppressive properties of MSCs are such impressively working? Mainly because of the safety concerns of using the whole cells. So we thought of an alternative, such as extracellular vesicles. They are the elements of cell secretome that are the elements of their membrane containing nucleic acids, lipids, and proteins of their mother cell. So they should have the same properties or similar. We wanted to check it, so we isolated EVs from MSC's medium and check them for MSC's characteristic markers such as CD73, CD90, and CD105. We also did the PBMCs experiment, in which we can see with the increasing dose of EVs, the ability of lymphocytes to proliferate decreased. We also were curious how each of pro-inflammatory cytokine influences the MSCs. So we stimulated MSCs separately with interferon gamma, TNF-alpha, and interleukin-1 beta, and did the analysis. So on gene level, we can see that the relative expression of PD-L1 increased only for interferon gamma stimulated cells, and the protein level confirmed that 100% of interferon gamma stimulated cells were positive for PD-L1. On the other hand, the relative expression of interleukin-10 on gene level increased only for interleukin-1 beta, but in the protein analysis, we can see that the interleukin-10 secretion was increased in the progress of time for also TNF-alpha stimulation. And because we read in the literature that interferon gamma stimulation can change the expression of HLA markers, we also checked that, and good for us, it didn't change the expression, the cells were still negative. And we also did the EVs mice model. But as we know, MSCs have to be stimulated to have the anti-inflammatory properties. And they can be stimulated in inflamed tissue. But we didn't know if the EVs will have the same ability. So in one group, we gave mice the EVs from unstimulated MSCs, and the other from stimulated MSCs. And similarly, we induce inflammation with HDM on black 6 mice, and on histological stainings, we can see the severe inflammation of the lungs from only HDM group, and both treated groups showed us that the inflammation was reduced. But we can see more differences on flow cytometry results. The frequency of interferon gamma secreting cells was decreased for both groups, but we can see that the primed EVs were more effective, and frequency of interleukin-10 secreting cells was increased only for primed EVs. But for better understanding the mechanisms of EVs, we did also the transcriptomic analysis, in which we can see that the clusters for MSCs and primed EVs are more similar to each other than for MSCs and not primed EVs. Also, we can see the FOXP3 upregulation for MSCs and primed EVs. That might confirm that the Treg response is the key here. And also we can see downregulation in eicosanoids and lipid mediator signaling for MSCs and primed EVs. So, results of our research confirm that EVs isolated from stimulated MSCs reflect beneficial effects of entire cells in regulating respiratory system inflammation. Also, we are continuing our research by optimization of storage parameters and stability assessments of new EVs preparate, in which we hope to make the preparate more available for patients and do a clinical trial in the future. So thank you for attention. I also wanted to thank my teammates for their work, and I'm ready for a discussion. Thank you.
Thank you very much. Any questions from the jury?
There was a lot. There was a lot of things happening in this presentation, so I think we need like 30 seconds to think. Would you mind going back to the slide with the results? Yes. So in the first experiment, you were using entire MSC cells.
Yes.
And that were administered to the mice model, and you have observed that the entire cells have made the inflammation mild. And comparing with only using the extracellular vesicles or the cargo of the extracellular vesicles, you have observed that the process was even the process of lowering the inflammation was even longer. Yes.
No.
No. Okay.
We had also the shorter model to see the the short-term effect. So in which we can also see that inflammation is reduced, also for flow cytometry. So the effect is like in short progress of time, but we also wanted to examine how long it lasts, and we suspect that the treatment in future might need the multiple administrations, but we are going into the direction. So we are planning on see into this closer, but now we have these two models, and we can see that the effect is in shorter time than these 22nd days of experiment.
Okay, thank you. So the idea is to use not the entire cells that may have broader effect, not only broader immunomodulating effect, but to use the extracellular vesicles.
Yes, extracellular vesicles are easier to obtain, to store, and MSCs have to be alive. So it's the most difficult thing to do in the treatment that we can maybe use in hospitals or maybe in preparates for patients. And EVs are like, now I'm doing my master's degree on this project I mentioned earlier. And the project from Student Scientific Labs Create Innovations. So it's combined my master's degree in this project, and we can see now that the storage of EVs is not as needy as storage of whole cells. So this was our main problem with cells, and also that we don't exactly maybe can see into the future how the cells will maybe behave, yes, in lungs, because they can differentiate, and the studies show that they, for example, healthy patients, they died and there are no negative effects, but there is also the need of multiple administrations, so it's better, it's too high risk. If we can do this alternative that seems to be promising, and we are really close to do a clinical trial, so I'm glad I'm going to participate in it.
Okay, thank you very much. So maybe one more question. The extracellular vesicles are obtained from the MSCs, from the model, but in future you would like to obtain them from the donor, from the person to which it will be futurely.
No, they don't have to be obtained from these patients that will be administered, because they don't have HLA and etc. So it can be like divided from one donor and transferred to another, because it's from medical waste. So in fact, like it's the waste after the abdominoplasty surgery, and we used it, and it give us hopes that it will be like good treatment for another people, because the T2 low asthma inflammation isn't really good responding for the treatment that we have now, and this is very promising.
I think it's very promising, especially when you don't have to administer the cells, because the cells should have been obtained from the donor.
Yes,
the
and
donor slash the person who will obtain the treatment.
Yes, and we are thinking about nebulization for administration, so it will be very easy to administer for patients.
I've got a question about the antigen you used. You used the dust mite, right?
Yes.
What do you think about other antigens? Pollen, for example. The results will be the same, similar, maybe different?
Each of these stimulators can have different effect. So this is the model obtained in Swiss Institute of Allergy and Asthma, and we use this. This really good, very well reflects the T2 low inflammation. We could also use ovalbumin, but we focused on this model because we have a friendly relationship with the Swiss Institute. We work together, and it's our most maybe we are certain for this model, so we used it.
But maybe you should think about extending the experiment about different antigen.
Yes, this is a good idea. I think we are going to do this in the future. We have many projects that are familiar with this subject, so we are really widely seeing into the topic.
So next we have Barbara Pernack presenting.
Good morning, ladies and gentlemen. My name is Barbara Pernak, and today I would like to present the results of our national study on the frequency of diabetic ketoacidosis in children newly diagnosed with type 1 diabetes in Poland, and how this trend was affected by the COVID-19 pandemic. Type 1 diabetes is a chronic autoimmune condition that leads to the destruction of pancreatic beta cells and absolute insulin deficiency. Today, we are observing an alarmingly high global increase in type 1 diabetes incidence. For instance, in Poland, in 2022, we detected over 32 cases per 100,000 children. Delayed diagnosis of type 1 diabetes can lead to one of its most life-threatening complications, that is diabetic ketoacidosis, or DKA. This is a severe metabolic state resulting in multiple short and long-term consequences, and eventually even death. The general biochemical criteria to diagnose DKA include blood glucose concentration over 200 milligrams per deciliter, venous pH below 7.3, or serum bicarbonate ions concentration below 18 millimoles per liter, and presence of ketone bodies in blood or urine. The aim of this study was to estimate how the frequency and pattern of DKA changed in children newly diagnosed with type 1 diabetes in Poland from 2018 to 2022, with a particular focus on the COVID-19 pandemic period. We conducted a retrospective analysis using data from all pediatric diabetes reference centers in Poland. And to our study, we included all children with a new symptomatic diagnosis of type 1 diabetes and available venous pH data. We defined DKA following the ISPAT 2022 guidelines mentioned before, and we defined the COVID-19 pandemic period as from March 2020 until May 2022. Moving to the results. In the analyzed period, we detected over 7,000 cases of new onset type 1 diabetes patients. However, after applying inclusion criteria and accounting for missing data, to our final analysis, we included over 6,500 children. We found out that alarmingly, more than half of children diagnosed between 2018 and 2022 presented with DKA on admission. Moreover, we observed that the DKA rate increased significantly during the analyzed period, from 48% in 2019 to nearly 59% in 2020, which was the first pandemic year. Additionally, when analyzing more region-specific data, we observed that some areas experienced even higher local peaks compared to the national average. This highlights that pandemic-related diagnostic delays may have affected some areas more than others. In our further analysis, we created a model to estimate the DKA rate if there was no COVID-19 pandemic. And then we compared the real observed DKA rate with the modeled DKA rate if there was no COVID-19 pandemic. This blue line here represents the real observed DKA rate. However, this new appearing line represents the modeled DKA rate, that is DKA rate if there was no COVID-19 pandemic. As you can see, our model significantly underestimated the DKA rate by over 9 percentage points. Next, to further explore the DKA trend with pandemic, compared to pre- and post-pandemic period. Secondly, children diagnosed during the COVID-19 pandemic were more likely to present with severe DKA than those diagnosed before and after pandemic. And finally, our findings show that pediatric diabetes care is highly sensitive to healthcare disruptions, such as the COVID-19 pandemic. This highlights the importance of early diagnosis strategies, including education and screening programs, to reduce the high rate of DKA at diagnosis in the future. However, as someone smart said, the future is now. So at the end, I would like to mention that a few months ago, Polish Society of Pediatric Endocrinology and Diabetology started a new national campaign that aims to reduce the high rate of DKA in newly diagnosed patients by educating both children and their legal guardians about first symptoms of type 1 diabetes. But this is not everything. We also participate in several screening programs that aim to detect subclinical type 1 diabetes patients, that is those who don't have any symptoms of type 1 diabetes. However, they have autoantibodies in their blood. And by detecting them, we can prevent severe metabolic complications such as diabetic ketoacidosis in children and also adults. So today I showed you that we have a high rate of DKA at diagnosis in pediatric population, but I also showed you that we have tools and knowledge how to prevent this high rate of DKA in new onset type 1 diabetes patients. So now we can catch this disease early enough to prevent DKA in new onset type 1 diabetes patients, because with those tools and knowledge we can. Thank you.
I'm interested in this model of diabetes if there was no pandemic, okay? Because there is a quite high difference between actual episodes of diabetes and the model. Is it only because of late diagnosis, or maybe there were more factors affecting children at this time?
Of course, diabetic ketoacidosis may develop due to stress, for example. Sedentary lifestyle is also a risk factor for diabetic ketoacidosis. And as we know, during the COVID-19 pandemic, during lockdown, we observed usually sedentary lifestyle. However, I believe that due to limited hospitalizations and decreased number of scheduled admissions at the hospital, for example, diabetological departments, patients could not access medical help as soon as they needed to, and in this way we observed this high rate of diabetic ketoacidosis in children newly diagnosed with type 1 diabetes. It is also worth to mention that our model, as you can see, it also We can also see in this model that the DKA rate would increase even if there was no COVID-19 pandemic. But the real observed DKA rate was even higher than that.
Yes, I see that, but I mean about other factors, lack of physical activity, for example, because many children during, especially lockdown, they gain weight quite heavily. Many of them gain weight, and that also can affect occurring diabetes, right?
Yes, I don't say that the COVID-19, because those children, they are not, they didn't have COVID-19 infections because we didn't explore that. We wanted to explore the effect of COVID-19 pandemic in general. So lockdown.
Yes, I know, and I mean, their activity during when they stay home, they don't go to school. They are not infected with COVID, but still, they've got some sweets at home.
Yes.
They're using only computer, and it results in gaining weight, obesity, diabetes, and other metabolic problems.
Yeah, I'm aware that there are many factors influencing this high DKA trend during the pandemic, and not only during the pandemic, but also now and before.
I think so. The main problem is the later, you can say, diagnosis about this diabetes. So, is any idea, any program of the screening test or something like that, routine method of laboratory diagnosis of this diabetes?
Do you mean subclinical?
Yeah.
Yeah, there are several screening programs all around the world. In Poland, we participate in 2 of them. Inodia Detect and Identify, and those screening programs are addressed to children, all ages, to detect autoantibodies in their blood. This is a low invasive test from their blood, and by detecting those autoantibodies, they are under diabetological they have diabetological assistance, and they are prepared somehow to, if they will develop type 1 diabetes in the future, they are prepared somehow because they know how first symptoms of type 1 diabetes look like. They know how to behave. They know how to eat. That activity and exercises are very, very important.
One short question, because when you were preparing the model, if you can switch back to the model, you were using the data from previous years.
Yeah.
And there we can see that there are the oscillations. And those oscillations were still kept in pandemic, but they were also observed in your model. Those oscillations during the year, what's the source of the differences?
So this is scientifically proven that type 1 diabetes occurs more often. We observed higher type 1 diabetes incidence during winter and autumn. Those oscillations are from those months.
Okay, and also during winter and autumn we had the peaks of COVID, so people were more kept in-house, so some things were just obscured by the COVID. Okay, thank you very much.
Do you have any other questions? I'll answer them all.
Thank you, Barbara. We have one more presentation from Arthur Jarash, and then we're going to have a short break after that.
Yes, but
Who's up?
Is Arthur with us today? Oh, hi Arthur, how are you? Perfect, I'm just gonna open your
Good morning, everyone. My name is Arthur Andreas, and I'm here to present to you our project on the development of a refined blister formation model aimed at elucidating interleukin-17B functions in the inflammatory response associated with bullous pemphigoid. To put it simply, we wanted to provide tools in order to determine if interleukin-17B is a valid therapeutic target for bullous pemphigoid patients. Bullous pemphigoid is a rare autoimmune disease which mainly affects the elderly patients. It manifests as itchy blisters on urethral plaques. Bullous pemphigoid is caused by circulating autoantibodies against two proteins, BP180 and BP230, which together with an inappropriate inflammatory response cause blister formation. Our team has detected interleukin-17B in the blister fluid of bullous pemphigoid patients. What's more interesting, interleukin-17B was correlated with the severity of the disease in a way where patients with low interleukin-17B had more severe manifestations of the disease. This led us to a hypothesis that interleukin-17B has a potential protective role in blister formation in bullous pemphigoid. To test this hypothesis, we had to create tools. We wanted to identify which cells can respond to interleukin-17B. We wanted to create a tool which we will be able to use in our lab to see how interleukin-17B affects blister formation. We also wanted to investigate the presence of innate lymphoid cells in the blood of bullous pemphigoid patients. We started with investigating innate lymphoid cells in the blood of bullous pemphigoid patients. We used flow cytometry. As you can see, bullous pemphigoid patients have a bigger concentration of innate lymphoid cells compared to the controls. What's more, these innate lymphoid cells are more activated, as characterized by the internalization of the CD127 marker. This marker is less expressed in bullous pemphigoid patients, which means the cells are more activated. There was no difference in subtypes of innate lymphoid cells between bullous pemphigoid patients and controls, and the activation is present among all subtypes in bullous pemphigoid patients. After such promising results, we conducted another flow cytometry analysis to determine if receptors for interleukin-17B are present on lymphoid cells, innate lymphoid cells, natural killer cells, lymphocytes, and monocytes. As you can see, in our patient cohort, the receptor interleukin-17A was present among all the cell subtypes. Meanwhile, receptor interleukin-17B was absent. Two of our patients experienced a relapse. This gave us the opportunity to see how the expression of the receptor changes due to the therapy. We analyzed their blood in 3 visits, and as you can see, there is a decreasing expression of receptor interleukin 17 RA. The next step was to develop a model which we would use to determine what effect does interleukin 17B have on blister formation. The setup of this model is presented on the current slide. We use a cross-section of healthy human skin. We use autoantibodies that are present in bullous pemphigoid sera and granulocytes. Altogether, this should present under the microscope as a subepidermal blister formation due to the effects of metalloproteinases released by granulocytes. To set up this model, we started with assessing the quality of our healthy human skin. We dyed them with hemotoxin eosin. We then had to evaluate if the autoantibodies do indeed bind to the antigens. We incubated healthy human skin with sera from bullous pemphigoid patients and used immunofluorescence to stain the dermal epidermal junction on which the antibodies are present. As you can see here, there is a green line on which represents the autoantibodies binding to the dermal epidermal junction. Secondly, we had to check if the granulocytes do indeed adhere to the dermal epidermal junction. Therefore, we incubated the skins with granulocytes. As you can see on this slide, granulocytes are attracted to the autoantibodies and are highly present at the dermal epidermal junction. We later optimized granulocyte concentrations and used an artificial way of inducing the granulocytes to create blisters. Since we wanted to quantify this method, we had to quantify it in a way where we wanted to measure the distance at which the dermal epidermal separation appears. We had to visualize it better. To aid came again immunofluorescence. Here we decided to stain, as previously, BP180 autoantibodies with FITs in green and collagen 4, which is present at lamina densa, in red. When we overlap the two images, microscope images, we get this photo. As you can see, the dermal epidermal junction is highlighted in yellow. Now, the success of this work is a new way of visualization of blister formation in cross-sections of human skin, where a subepidermal blister is visible as the lack of colocalization between BP180 and collagen 4. This work was conducted in collaboration with University of Reims Champagne-Ardenne in France. Thank you for your attention.
Thank you so much. So there will be a quick break before Professor Benedetto will introduce us methods of robotic surgery. The presentation will start at 11:30.
There's tea.
Take a seat. The presentation will start soon, so.
If you don't mind, please come closer. Please. Those guys from the last line, please come closer. So we can really feel that you are here and you can make any question or whatever. So please come closer, don't worry. Closer to me. It's not only a one-man show, this is a conference for everybody, so we can collaborate, and I need all of you very close. So it's easier to share our experience and our feeling and emotion about this. Come closer, come on. Don't be afraid. Okay. Shall I start? Okay. So we can just talk each other's. It's not gonna be a one-man conference. So we are gonna share all of these and starting with this one. So in first line it's me and a patient, and then in the back is a robot. It's not only a picture, but it's something which is really very important for me that I want to transmit to you. You are going to be great doctors, hopefully surgeon as well. But what is important is just to be close to the patient. So thanks to the technologies that we are using right now, we can make really great procedure to be a great doctors, but always take in mind that the patient came first. And you have to be very close with the patient. So before starting, I really want to thank all of you for your kind invitation. There are some colleagues which are also friends, Piotr Adams and also Wojtek, who have been with me last week in Barcelona. So really thank you for this kind invitation. And I'm going to start also with the chronometer, so I'm on time. Sometimes technology is not working. And now, yes. So I just want to start with what was my first impression with the robots. When I was a resident in Madrid, I'm Italian, but I live in Spain, in Madrid, where I was trained to be a surgeon. Well, the first time I saw the robot, which is this model, a very huge, big one. It was the first robot, surgical robot in Madrid, in old Spain. And I was really getting impressed. I saw, come on, this is a robot. I'm not going to touch the patient. It's the robot through my hands moving this and making the procedures really fantastic. I really get impressed in that. This is the photo that I did in the very first procedures, which I was assisting like a resident. And then it changed completely my life because I decided when I finished my residence really to take advantage of this. So I was searching for an hospital with got robots, and then I get my first certification, and it is me almost 10 years ago. I didn't change quite a lot, I think. And this is my first certification in 2014, and everything started from this part. And why we are here, why you invite me to give this talk? I mean, it's a surgical talk, of course, but I just want to transmit you that you are young doctors. You are going to live a special moment in your life, which is the exciting robotic medics. What does it mean? That it doesn't matter if you are going to be a surgeon or not, but it's true that you're entering in a special moment, a modern era, where new technologies, especially robots, are going to be part of your clinical practice. And this is a surgical talk, so I have to talk about some procedures. Why the title of this speech today, where we move from laparoscopy to robotic approach. Laparoscopy, it was really very important. It still is very important. It started almost in the 90s, and almost all of you know what does it mean. There's no need to explain what laparoscopy is. But there are some inner limitations. when we started doing procedure by laparoscopy, we are minimally invasive procedures. We're really going to give a lot of benefit to the patients, reduced pain, blood loss, length of stay, but a big effort for the surgeon, because it's not that easy to make important procedures only with 2 or 3 holes. So, which are the real issues, topics that we have to think about that in laparoscopy, which are the limitations? We need to see better and we need to manipulate better, which is the real two most important limitation of the laparoscopy. So what we can do about this? Just transforming this in a new technology, which is the robotic, which is really try to answer to this issue, giving a better visualization and a better manipulation, still through a minimally invasive approach. So for instance, I started this study trying to understand which are the real benefit of the robotic compared with the laparoscopic approach. For instance, lymphadenectomy is part of a surgery that you need to do for oncological reason, for cancers, which is very difficult to do by laparoscopy. There are very little nodes that you have to dissect, and with the limitation of the laparoscopy, it's not that easy. So I thought maybe with the robot it's going to be better. And what we show in this paper is really we can get more lymph nodes thanks to the robotic. But why? Because of this, you can compare the laparoscopic one from one side and the robotic from one side. You can see that is the same procedures. This is the lymphadenectomy, but you can see that we can do much more better with the robots. And also the anastomosis of the pancreas, which is one of the most challenging part of the procedures in pancreatic resection. So this is the open anastomosis compared in between robotic and laparoscopic one. So as you can see, those are very challenging procedures, which is very difficult by open approach and really very difficult by laparoscopy. So which is the gap in between the open and the laparoscopy? It might be the use of new technology like robotics, which is really doing the same movement of the open approach, like the biliary anastomosis as well. Those are videos just to give you an idea of what is the real benefit of robotic, but it's very difficult to transmit this in evidence, in a paper. But also there is the seduction to be sitting in the console where you don't really feel, you don't sweat, don't have any tremble, you are very comfortable sitting there. And also the assistant surgeon, sometimes in the laparoscopy, you know what happens, it's something like this. You are really struggling in between 2 or 3 surgeons. It's like a twister. I don't know if you use this one. It's a very good game. And when I started laparoscopy, it was something very similar. So when you touch it's not that easy. And also this very nice publication where it says there's some doctors, some surgeon, laparoscopy surgeon in the United States, they have to quit the job, they have to retire very early because some physical strain because of these procedures. And when we are talking about laparoscopy complex procedure, we're talking about procedure that might last even 6-10 hours. So imagine being there and in touch with other colleagues and for such long period of time. But even using technology and robot, you have to understand how to sit properly. You have to avoid this position in robotics. So it's not only the robotics that really increase the ergonomics, but it's you that also have to learn how to use this technology properly. That's why it's very fine, this photograph, because this is taken from the internet of Intuitive, so the cost of the robot is 2 million, but they the photo, they just show a 20 euros chair, so there are a lot of things to be changed. Also there's some problem to be sitting all the time. We are, guys, we want to move, we have to increase our movement. And sitting is a new smoking. This is the publication. So what they said, and making long the surgery is true. We are very comfortable with increased ergonomics, but we are looking for something maybe different that is for right, like in this robot, where you can stand and whenever you want, you just load the bar and then you can sit. So it's something a little bit more dynamic. So don't imagine the robot only with something that you have to sit and to work, but something which is more dynamic as well. But I don't want you to think that you are very far away from this technology. So everybody are asking me, well, Benedetto, you are talking about robot, but yet in my hospital there is no robot and there's no idea, my director, they don't want this robot. And it's true, but this is the picture, worldwide picture of the robotic surgical system in the world. And you can see that is increasing, this is increasing, so the war is going to happen also in your hospital, in your center. They are going to arrive, there is nothing that can stop real this technology to arrive in your hospital because it's a normal evolution that started not 1 year ago, but almost 20 years ago. So the first robot started in Europe almost 20 years ago, so it's 2 decades, and it's little by little growing, and anytime it is growing even faster. But you are in a surgery room, you are doctors, you don't have your robot still, but still laparoscopy is very, very important. It's the basics also to develop your skill in robotic. This is a timeless value of the laparoscopy. Also because the laparoscopy we are talking about today, I'm sure that you students have been in a surgery room watching the laparoscopy. It's not the laparoscopic that I saw almost 10 years ago. It's a new type of laparoscopy with a new technology like this one, which is still I'm using. I'm still really convinced that the laparoscopy has an important rooms in surgery. So this is an optic flexible, which is not still available in robotic as well, which really helps me to make some procedures. It's not the screen, the optic of some years ago. It's a very high quality defined optics, also ECG, cyanine green, that we use to localize some tumors, some anatomical landmarks, but also in laparoscopy is not like in the past. It's a very good quality, it's working quite well, for instance, to localize the splenic artery. Also the vision, there are some laparoscopic optics that really you can control directly with your device. No need for any assistant surgeon helping you. So you have a very good quality of vision, also stabilized vision, also in laparoscopies. Just to say again that this is not the laparoscopy of the past, but it's the current laparoscopy. Also the articulated instrument of the robotics. There are now tools, laparoscopic tools, which take advantage from the technology of the robot, and they move this to the laparoscopy, like this one, which is exactly the same technology of the robot, but is in a laparoscopic device. So this is the laparoscopy that you are going to use, even if you don't have the robot. But those are the basics. So when the robot is going to come in your hospital, you really are going to do very well because of this. So still go on with laparoscopy. And also, I have this thought. Sometimes I think that also laparoscopy is changing, it's moving, and robotic as well, something like an fusion. You saw the robotics is getting smaller and smaller. I showed you the previous robot that I saw almost 10 years ago. It's completely different from the one that we are using, very similar to laparoscopy. From the other side, also the laparoscopy instrument, they are taking advantage from the robots. So in the near future, I feel something like this. This is me working in the new robot, the first Spanish robot, which we are developing and collaborating, which is real, the hybrid robot, which is a laparoscopic robotic robot. As you can see, this is using the same laparoscopic trocars, which are the main entrance for the procedures. They are using the same optic of the laparoscopy, but integrated in a robotic system. So this is the robotization of the laparoscopy. So in the near future, it's not a matter that laparoscopy is going to disappear and robot is going to replace. No, it's something like there is a robotization of the laparoscopy. It's going to be a fusion of this. By the way, this is a very good robot for some procedure. They already started some clinical trials also in my hospital. The single port, there are still some advantage of robotics that laparoscopic still didn't have the chance to develop, like the single port. The single port is the access of our procedures for a single trocar, a bigger one, trying to decrease the number of little main entrance trocars of the abdomen, which is very, very tricky to do by laparoscopy, because it's something like this. if you want to eat this tagliatelle by multi-port, it's much more easier, but with a single port, you have to make these procedures only with one port, and so the instrument are going to really make a conflict. It's not easy to move, and sometimes we have also to cross your arms, and that's why in the single port in laparoscopy they didn't really develop a lot. But what is happening? Something like this. This is the new robot, which is not really very new because it had been developed almost 5 years ago, and it's the single port by Intuitive, but there are some other robots of single ports, and this is the procedure of cholecystectomy. So this is the real advantage of the robot that still we don't have in the laparoscopy. So it's an integration. So you're really very comfortable, sitting in your console, making the operation, but then you can really integrate all of this. You don't have to cross your arms, and you're really very comfortable on doing these procedures. But really, there are some other robots as well. So this is the Mira, for instance, that I had the chance also to try in the United States, which is really the smallest single-port robot never built. It's only this one, okay? It's just built in the United States, and they send you in a pack, a very little one, and you can just place in the patient, and this is the console, of course, that you have in your hospital. It's a single port, so you can make procedures only one single incision, and it's not the future, but it's the present. With this robot, it's already been done almost 20 right hemicolectomies, so really important procedures. And also, you can see there's some little part that you can throw it. So what is also important, try to decrease the footprinting in our wall, and this is a very good alternative. The Shirui, which is from China, the Eastern world is really building very, very interesting robots. They're using the technology already available, which have been developed mostly in the Western world, but they're doing really a very good job. So this is a very high advanced single port robot, which is the Shirui. Just to give you the idea that whenever we talk about robots, I don't like to talk about the Da Vinci, but there are different types of robots they are developing. And also about the proctoring, you can tell that with a robot you can teach better because you have another console. But still, with the laparoscopy, it's not like in that picture. You have new tools for training in laparoscopy, which are really very good. And there's no need to have the robot to train properly. And for this aspect, I'm going to be a little bit criticizing all the papers which are showing shorter learning curve with the robot compared with the laparoscopy. Also because it depends on you. It depends on your teacher, on your professor. If he is really kind to teach you, of course it's going to be faster. My teacher who teach me the robot it's a veteran one with no mentorship, no specific training. But me, I had him with a mentorship. He teach me. I have some of a specific training. But all of you are maybe in the Zeta or high generation resident fellow. You are going to make this really, really faster. So the learning curve is going to be really, really much more quickly. And this is what I'm engaged in. So if you come to my hospital, really my main objective is to take care of the patients, but helping also new surgeon, student, doctor to learn this technology. And also this is the reason why I built this platform, which is Virtual Surgical Masterclass, where you can really see the procedures without any edition, mainly live, something like the Netflix of surgery. So if you subscribe, you receive every week a schedule of the procedures which are being performed from other countries as well, with the main objective to share experience and to see how it may happen in our country and to learn. And what about the cost? Because it's also very important. Whenever we talk about new technologies, of course, new technology increase the cost, which is true. Robots are much more higher cost compared with the laparoscopy and even with open approach. But the same happens also with the laparoscopy. The laparoscopy was a bit decreasing generally the cost of the procedures. Right now, we don't have to look only on the cost. We have to switch. we have to move from cost to cost efficacy. So we have to balance the cost of a procedure with the quality of life. And we do the balance. We may accept in our society, healthcare system, that we can assume more expensive procedures, medication, for a more effective results. So this is real the quality of life of the patients, the effectiveness. And this is the cost effectiveness study. And this is a study that I started 3 years ago in Spain. We already finished it, where we prospectively recruited some procedures, almost 700 procedures, comparing the laparoscopic and robotic. And we published this in surgery, in surgical endoscopy. And if you are interested, in the QR code you can see which is the real cost of those procedures by robotic compared with the standard laparoscopy, which is not that higher if you do properly. Of course, first cases are going to be a little bit more costly, but little by little, if you learn the technique, you can really achieve the same cost of the laparoscopy or open approach, increasing the quality of life. And again, I want to be back on the cost and also the concept of the new robot. It's not always talking about the Da Vinci intuitive, but there are new robots like this one. They want to be not the new Da Vinci. They want to be the robots all over the world. And what does it mean? The new robot is also less cost. In fact, cost decreases quite a lot with the entering of this new one. For instance, this is the Banter robot that I tried, and this is from India, which is a very good one, a very good alternative. I tried also in a peak, which is working really, really, very well. You are in an open space, and it works very well with a lower cost as well. And this is the Medbot, which also from the Eastern world, which is very similar to Da Vinci. But they really are going to decrease generally the cost of these robots. But really, after all this talk, which are the real evidence? There are real benefit of the robot compared with the laparoscopy, because at the end, apart of what I think, we have to rely also on evidence, scientific evidence, which is not that easy, because now we are comparing the robot with the laparoscopy. The current laparoscopy is not that of the past. So it's a very good one. And what's up in the literature? Because even if there are a lot of publications, so if you open PubMed and you just write robotic procedure, there are quite a lot of those. Doesn't mean that really there are evidence, because most of those are retrospective series. And whenever we talk about evidence, we need randomized clinical trials, extended review randomized clinical trials, which are prospective study, very difficult to run, especially in surgery, because of a lot of limitation in surgery. For instance, this is all the randomized clinical trials comparing pancreatoduodenectomy, which is the Whipper procedure, one of the most difficult one, comparing open versus minimally invasive. There are only 8 trials talking about this. But mention that the first laparoscopic pancreatoduodenectomy was done really a long time ago, in 1994, and the first robotic one by Giulianotti in 2002. But the first randomized clinical trials was done almost 20 years after the first procedures. So evidence, randomized clinical trial, took time. We are really working on that, so we need time to find evidence. So don't think that if there's any colleague telling you, there's no evidence about what you are doing. Come on, we are working on that. So we are still trying to make more research, and there are non-inferiority studies, which are showing the robots are not inferior to laparoscopy. Like this one. This is an important journal, maybe the best in surgery, that is telling us that robotic is not giving any advantage to laparoscopy. No. What this is telling this paper is that there is no inferiority. So the robot is similar to the laparoscopic cholecystectomy. It depends on what we think about, but right now it's safe and effective like laparoscopy. So the first stage of the evidence. Then we will run randomized clinical trials. But also, a part of the evidence is also the experience piece, what we really saw in our patient making the procedures. And of course, the paper talking about cholecystectomy for robotics is a little bit dirty, in my opinion, because we need the robot for which type of procedures. In my opinion, we need this right now for this stage, in this moment of our life, for very complex procedure like pancreatoduodenectomy, and not for cholecystectomy, which is unfair to compare laparoscopy with robotic, in my opinion. And this is also true. This is happening in all around my clinical trials. We participate in the Diploma 2 trial, which is maybe the most important, comparing open versus minimally invasive in pancreatic resection. But as you can see, 19 cases of laparoscopy, 10%. All the other cases, they are robotics. What does it mean? That people, surgeons, they really don't want to make this procedure by laparoscopy. They need a robot for very complex procedure, which is something happening in our region, in Catalonia, in Spain, where in this year you can see that the robotics is really increasing in pancreaticodenectomy and decreasing the laparoscopy, replacing the open approach. So really, just to say again that we need this robot right now, in this moment, for very complex procedures, but you need to do also cholecystectomy, easy one, just to learn the technique and to increase your learning curve. But also, it's not a matter of procedures, also a matter of subgroup of patients that really may benefit from robot more than other group of patients. Like in this PANFRAIL study that we are running, where we are looking at more fragile patients, obese in the elderly, more than 80 years old, that those patients may benefit from robots compared with some other procedures to very complex surgery. So this is a study that we are running worldwide, and we included a lot of centers, as you can see here, and also there is Giulianotti. Remember, this is the first surgeon doing the first many robotic procedure like hepatectomy, pancreatectomy, and gastrectomy by robotics. So really, it's an honor for me to have him involved in this project. But this is a very nice picture that I found in France, and showing a long time ago what is going to be the future of the robotic surgery rooms. And they are very, very close to what is right now. This is a robot pigeon. They were depicting this hundreds of years ago. And they are very close. So just to tell that we are really on the beginning of this robotics. The robotic of the future is not going to be the robot that we are seeing right now. So we are just at the beginning. Also because it gives you the chance really to integrate all this stuff that we saw in only one system, like the mobile. No? Now we have only one mobile integrated all the stuff that we're using in the past. And also give the chance to make operation in telemedicine, telesurgery. So you are far away from your patient in other country, and this is something that you think that is going to happen in the future. No, it already happened almost more than 20 years ago. The first procedure was done in 2001, the Lindbergh operation, using another type of robot. The Da Vinci was still not available, the Zeus. The patient was in Strasbourg, and the surgeon, Marisco, in New York, making this procedure, a safe procedure with some little delay, but it cost quite a lot. But right now what is happening is this. In Japan, for instance, is something that happens every day. Every day they do this surgery. We don't talk about this a lot, but really, you can stay wherever you want in Japan, you can make a procedure, no matter if it is close or far away, and this is not the future, this is really the present. But what is the future, which is maybe is going to be very, very far away? It is one. They want to make procedure also in the space. We will see what happens when we are going to live in Mars. But you know, those are Americans, and they also simulate an operating room in this aircraft without gravity just to see what happens. You know, Americans, they are like this. They want to probe it. But really, it's going to happen. Maybe they are going to send this little robot, like the mirror that I showed you, in the space just to make these procedures. But also, the robot is a system which really give us the chance to improve also the quality of our surgery, even if there are no evidence. And why? Because, for instance, airplane, there are some accident, and most of the time 50% are because of pilot error and driver errors in the car accident. Really, these are not my number, my opinion. Those are really from internet. 80% surgeon error mistakes from internet, but from publication, official publication. And this is true. We are surgeons. We can make mistakes. It's not malpractice, not because we want to make the mistake, but this error can happen during the procedures because of the inner complication, the inner difficulty of the procedures. So what about this? this is the AI really helping us to decrease this. And this is not something that is in the future. It's real in the present. We've been talking about this. There are technology already right now still available to improve some techniques like the anastomosis. We've been talking about this. You do a cholecystectomy, so there is a special machine, the sensor, which is really taking care of you and telling, come on, this is an artery, be careful. Like the electric cars or the cars that we are using right now, they just advise you about the traffic lights, about any dangers. It's something that is happening right now. It's not the future. But again, what is important, I want to close the presentation, always telling you that let machine extend our hands, okay, but never replace the human touch. You always need to be very close to the patient. This is basic, it's very important. There is a robot in between the patient and the surgeon only during the procedures. But what is important that our patients still need us. They need the doctor to be very close to them. So don't let the robot be an helpful tool for the procedure, but still also let the robot increase also your taking care of the patient day by day, staying very close to him. So, thank you very much. Dziękuję.
Thank you very much for such an interesting presentation. Here's a present for you.
Thanks, Toro.
Do you have some questions to
Yes,
Professor?
of course. I'm expecting some questions. Come on. Otherwise, you are not so close.
Thank you very much. I've got one question. What do you think, in which type of surgery the robots will bring the biggest improvement? In what kind of surgery robots will bring the biggest improvement?
Okay, right now, as I said, for very complex procedures. So, as I told you, for laparoscopy, there are still important limitations, so you can angle very well. So, any times, in my opinion, there is a procedure that needs very important angle, like lymphodectomy or anastomosis, the robot really is going to give a lot of advantages. That is the procedure, something like pancreatic resection or rectal resection, all these very complex procedures.
Okay, I think it will be very interesting to compare how big the improvement robots are between different operations. For example, pancreatic ductal, for example, Whipple operation, or for example, removing the gallbladder or something like that.
Yes, as I told you, for cholecystectomy there are several studies which are retrospective, so very limitation one. They are not showing in the big advantage of the robot in the laparoscopy. But again, for Whipple procedures, is the same. Looks like in the article is the same of the laparoscopy. But don't look at the advantage itself. Look at the fact that now surgeons, they are not moving from open to laparoscopy Whipple procedure. They're moving from open to robots. This is also an advantage that should be acknowledged in the papers.
It's also, I think, really hard to compare, to make a study, because you cannot blind. You cannot make a double blind.
No, of course. This is the important limitation of randomized clinical trials in surgery. So, if you want to make a double blind with a medication, you can't. It's impossible for surgery. But you can make something like a blind the patient. So what we usually do when we do these randomized clinical trials, we cover the abdomen in the postoperative course of the patient, so the patient doesn't know if he underwent to open, laparoscopic, or robotic. And so we make questions to the patient on the quality of life, decreasing the bias of the acknowledgement of the patient of which type of procedure has been done, which is something fair, in my opinion.
Thank you very much for this small discussion.
Benedetto, thank you very much once again for coming here. Dear colleagues, Professor Benedetto is one of the most famous robotic surgeons worldwide. So thank you very much for coming. And because of the fact, I would like to ask you a question about your road. Where did you learn it? How you did it? Okay.
Yes.
Animal studies, or mentors, or conferences. What is the most important thing in your opinion?
The most important is don't stay in the same place. Just move. What is important, but it's not in surgery. This is in every type of job. You have to build an important network and networking this. So you need to move from one side to another, to one center to another, no matter surgery, whatever you're going to be in the future. You don't have to stay always in the same place. Try to get out from your safety place. So this is very important. Don't stay always in your comfort zone. And this is the basics. On the side of surgery, I had very good mentor, very good proctor, and really I'm very grateful of that. And that is why I'm trying to be also a good proctor, because I had a good one. So in my opinion, if I'm also as well a good proctor, maybe resident, they are young surgeon learning from me, they are going to be as well a good doctor. And this is the basic of our life, just to improve the future, not only of medicine, but of our human being.
Thank you very much. So the road is very long, but we shouldn't be afraid of challenges.
No, don't be afraid about the challenges. In the mean, we are always together on this.
Thank you very much.
Thanks to you. Wojtek.
Thank you, Benedetto, for a great speech. I have a question, if you can say from your experience, your point of view, what is the safety of the learning curve for laparoscopic robotic surgery, because young surgeons, residents, trying to get more and more experience doing and developing more complex surgeries. And how would you say, is it like maybe an advice for tutors in Poland who will like in few years probably teach young doctors in the procedures? Should they be afraid of letting the young doctors doing the robotic surgery, or maybe it is more safe to learn in this way?
Well, I'm not the one that is going to reply to this because I'm very humble, but let's say that, in my opinion, is the same that happened also with the open surgery as well. I mean, the surgeon was helping a lot, and doing in some little step of the procedures in the open, like cholecystectomy. And then also in the laparoscopy, it's not a matter to leave the young surgeon with all the procedures, but after many helping, assisting procedures, started to do little steps, like you saw in Barcelona. So the young surgeons were doing the robotic patectomy, but most of the time they were not doing alone themselves, but little step, little by little, and in the end they are going to learn. So there is not a perfect safety way to learn. But really, in this current period of time, we have plenty of way to learn, especially thanks to the technology as well. We have applications, we have also scientific papers showing a lot of videos. If you see now, especially in surgery, there are not a lot of scientifics itself with statistical analysis. There are also a lot of video publications, which are really very relevant for learning curve. And this is my modest opinion. At the end, you have to really look at a very good proctor, which is patient and helping you little by little, which is also very little, also in current time, because we have a lot of caseload, a lot of work to do. The assistance is very impressive right now. For that reason, we need, especially in university hospital like this, the help of the director to give us a little bit more time to teach.
Yes, and maybe the last one from me, because of course in Poland, I think same in your country, we have a long line of the patients waiting for the surgery. And from my point of view, the robotic surgeries are quite longer, and you can do one surgery during the day, not 3 or 4 sometimes open or laparoscopy. So how do you handle this problem?
Well, it's not that easy. You have to discuss this with the director of the hospital. At the end, you saw the slower procedures done by the young surgeon, assisted by me, but you didn't saw me making the operation. So I did the operation in the afternoon by myself quickly. So it's a balance. So to teach you, the other side, you have to make this operation like you are doing properly, faster, in other moment. So just the balance. It's a win-win.
Balance and dedication.
Exactly.
Okay, thank you very much.
Thanks for question.
Okay, any other questions?
Yeah, I've got like a question to extend Wojtek's first question, because in Poland it's a normal stuff when third or second year resident perform a lap cholecystectomy. And how do you can learn someone who's starting the residency to perform surgery on a robot? Because in Poland you have to finish specialization, and after that you can start learning how to operate on robotic. So how can resident learn and operate by a robot?
No, it's something that's also happening in Spain and some other country. Being a resident, you have also the chance to learn the robotic yourself. I mean, if in hospital you have a robot, when the senior surgeon already learned this technique, after that, it's important to give the chance to the young surgeon, to the resident, to do a little step of this. So this is the way to learn. Of course, it means that the procedure is going to be a little bit longer, it's going to last a little bit more. But you have the big chance also to learn during the residency. Like you learn laparoscopic cholecystectomy. You learn this not after the residency, but during your training. So it's the same in the robot. It's going to happen very quickly, in little by little, but this is something that is going to happen very, very, very soon.
So you're allowing the residents to perform minor parts of the surgery during your operation?
It was with me, yes, they are doing, which is very important. I mean, why not? Can I ask you why they shouldn't learn?
I think we've got all the surgeons who can argue with that, right? So maybe Professor will
I think that you should keep faith, because the first laparoscopic cholecystectomy done in 1991 in Poland was done not by the head of the department, by two assistants. Professor Krawczyk was one of them. He was a professor at this moment.
Yeah, sometimes, especially surgeon, we want to be one-man show. We are very big ego, especially surgeon, and I'm always telling also to myself that we should be very humble. There's no need to have this big ego. What is important, just why I show you the picture, is the care of the patient at first, and then the rest is not important.
Okay, someone else? Okay, thank you so much then. There will be a tea break till 12:30. And there's a stand of Więcej Store, and I invite you to see their products, and there are small gifts waiting just for you. Thank you so much.
we have to return to the participants' presentations. I'd like to invite Jakub Czerwiński.
Good morning, my name is Kuba and today I would like to present you a project, the role of FGFR2 dependent signaling in regulating AP1 complex composition in luminal breast cancer. Breast cancer is the most common malignancy in women. The disease is highly heterogeneous and its most frequent subtype is the luminal breast cancer, which accounts for approximately 75% of all cases. Its main oncogenic driver is the estrogen receptor. Consequently, the standard treatment is anti-ER therapy. It prolongs survival, but over time, cancer develops resistance. Its molecular mechanisms have been the subject of extensive research for many years. The mechanistic data generated so far suggests the role of tumor stroma in the process of development of hormonal therapy resistance. In particular, interaction between fibroblast growth factor receptor and estrogen receptor. In vitro experiments have shown that activation of FGFR2 promotes tumor progression and development of therapy resistance. This mechanism is modulated by numerous factors, including the AP1 complex. It is a complex composed of, it is a dimer composed of yun and phos family proteins. In vitro experiments have shown that activation of FGFR2 induces expression of yun B and C-yun and alters the composition of the AP1 complex. This, in turn, may trigger ER activation via the so-called non-canonical pathway, resulting in tumor progression and resistance to anti-ER therapy. The hypothesis of the study I'm presenting is a proposed explanation of the mechanism in which luminal breast cancer bypasses estrogen deprivation. Fibroblast growth factor activates FGFR2, inducing expression of yun B and C-yun, activating AP1 complex. Activated AP1 complex activates ER, resulting in expression of genes associated with bad prognosis, progression of tumor, and resistance to hormonal therapy. The aim of the project I'm presenting is to evaluate in vitro findings in clinical material. In other words, to evaluate the clinical significance of the FGFR-AP1 axis. Specific objectives include analyzing the correlation between expression levels of FGFR2 and AP1 complex components, and correlation of obtained data with patients' clinicopathological parameters. 47 patients with luminal breast cancer have been recruited retrospectively. Archival postoperative formalin-fixed paraffin-embedded tissues were immunohistochemically stained, and expression levels of FGFR2 and AP1 complex components was evaluated using light microscopy. Subsequently, we correlated obtained data with patients' clinicopathological features. Following the subgrouping according to the expression of markers, we analyzed relationships and found a statistically significant, strong positive correlation between the expression levels of FGFR2 and yun B, aligning with in vitro data. The image shows performed immunohistochemical stainings to evaluate expression levels of FGFR2 and yun B in corresponding tumor areas. Despite identical histopathological type and immunophenotype of the tumor, patients' prognosis may vary significantly due to complex interdependencies between FGFR2, yun B, and ER. The co-expression of FGFR2 and yun B showed a statistically significant correlation with average tumor size. Surprisingly, higher expression levels of FGFR2 and yun B were associated with smaller average tumor size. Cases with loss of expression of both or either marker exhibited a larger tumor size. The co-expression of FGFR2 and yun B also showed a statistically significant correlation with levels of Ki-67 proliferative index. Higher expression levels of FGFR2 and yun B were associated with slower tumor proliferation. The co-expression of FGFR2 and UNB also showed a statistically significant correlation with histological tumor grade. Higher expression levels of FGFR2 and UNB was associated with lower histological tumor grade. We also performed an in silico survival analysis using publicly available data for expression of FGFR2 and UNB. As the red curve shows, the patients with higher expression of both markers experienced a longer overall survival. The study reveals that co-expression of FGFR2 and UNB correlates with favorable clinicopathological features, which is in contrast to in vitro data. This is probably because co-expression is not a proof of mutual interdependence between FGFR2, UNB, and ER. In the study that is already in progress, I will use proximity ligation assay to assess mutual interdependency between these components. Assessment of the clinical value of FGFR2 should be performed along with its molecular partners. This approach may potentially will potentially enable a creation of a prognostic and predictive a panel of prognostic and predictive factors. This will allow for more personalized anti-ER and anti-FGFR therapy in luminal breast cancer. Thank you for your attention. So we used a Spearman correlation, Uman-Whitney tests, and Kaplan-Meier test for survival analysis. Thank you.
I would like to ask about this FGFR2 factor. Is it only breast cancer connected with it, or other types of cancers?
Other types of cancers also shows expression of FGFR2, but its molecular impact is completely different than in luminal breast cancer.
So, elevated level of this factor can be result in only breast cancer developing or suppressing, or other cancer also?
Probably yes, but because there was the infragitinib anti-FGFR drug showed a good results in, for example, cholangiocarcinoma. So probably yes, but it requires further assessment.
So I think it is worth to check if there is no connection with other types of tumors, because in the case of patient, rarely patient, but with different types of cancers simultaneously. So it could be worth of check that, because it could be marker for different diseases, different types of oncological problems.
Thank you.
I wanted to ask, because you have a quite big group of patients, and here in those results, we can see, especially in those results when you are comparing two groups, we can see that there are only few, not that much patients included. So, how many patients were evaluated regarding the immunochemistry?
47 patients were evaluated, but not every patient, not every tumor showed expression of FGFR2 and UNB, so these cases were excluded.
Okay, and could you move to the last, to the Pentium Ultimate slide? Because with this curve, here we have this very big number, so this was where my question came from. This study was the study, here you are presenting the study related with the gene expression, not the presence of the protein, yes?
Yes.
Okay, thank you.
Thank you.
Someone? Question? Thank you very much. I will invite Natalia Anna Koc.
Dear committee, dear audience, my name is Natalia. I'm a fourth-year medical student and I'm representing the Scientific Circle of Neurosurgery out of Medical University of Gdańsk. Today I would like to present results of our study on the use of ultrasonography in assessing bypass capacity following revascularization surgery in Moya-Moya disease patients. Moya-Moya disease is a progressive occlusive cerebrovascular disorder mainly affecting internal carotid arteries and their proximal branches. Revascularization surgery, including direct, indirect, and combined bypass surgery, is an effective treatment to restore cerebral blood flow. While digital subtraction angiography remains the gold standard for assessing bypass patency post-surgery, it is invasive and associated with high radiation doses. Ultrasonography may offer a non-invasive, cost-effective alternative for assessing bypass capacity, however, its clinical use remains under investigation. Therefore, the aim of our study was to identify ultrasound parameters predictive of high bypass capacity following revascularization surgery in Moya-Moya disease patients. We conducted systematic review according to PRISMA guidelines, searching through PubMed, Web of Science, and Scopus. The inclusion criteria for the studies were reporting Moya-Moya disease patients undergoing revascularization surgery, ultrasound parameters post-operatively, and control imaging. Only English language studies with at least 10 patients and extractable data were included in the analysis. The quality of the studies was assessed using the Newcastle-Ottawa scale. Random effect models were utilized and patients were divided into direct, indirect, and combined bypass surgery subgroup. High bypass capacity was defined as good bypass patency or good collateral development following the surgery. This flowchart represents our screening process. Out of all records retrieved, we included 8 publications in the analysis. There are 264 cases and 326 operated hemispheres reported in 8 publications. High bypass capacity was observed in 169 hemispheres and 11 cases, and all of the publications were rated as of high quality according to Newcastle-Ottawa scale. Out of the 8 publications, 7 were prospective and 1 was retrospective study. 3 of the studies reported patients undergoing indirect revascularization surgery. 3 studies reported combined bypass surgery, and 2 studies reported direct surgery. The majority of the studies used color Doppler ultrasound as a chosen modality, with 2 studies assessing intracranial arteries with transcranial Doppler. And also the majority of the studies used DSA as control imaging. We managed to assess different ultrasound parameters at 3 time points post-operatively within the first 2 weeks post-surgery, between 0 up to 3 months, and between 3 up to 6 months post-surgery. Increased peak systolic velocity in the superficial temporal artery within the first 2 weeks post-surgery was associated with high bypass capacity with the mean difference of 28.26 centimeters per second, which indicates an early flow acceleration. Similarly, end-diastolic velocity in the superficial temporal artery within the first 2 weeks post-surgery was increased in high-capacity bypasses with the mean difference of 33.45 centimeters per second. And this, together with increased peak systolic velocity in the STA, reflects the blood supply coming from extracranial to intracranial direction. Mean flow velocity, which integrates flow speed and vessel diameter, was also increased in high-capacity bypasses within the first 2 weeks post-surgery, with a mean difference of 22.97 milliliters per minute. The STA resistant index was significantly lower in high-capacity bypasses within the first 2 weeks post-surgery, with the mean difference of -0.09, which reflects the reduced vascular resistance downwards, probably due to successful revascularization of ischemic areas. We also observed significantly lower mean flow velocity in the anterior cerebral artery in high-capacity bypasses after indirect surgery, with the mean difference of -64.98 milliliters per minute, which may reflect the redistribution of blood flow intracranially following the surgery. At 3 up to 6 months, the end-diastolic velocity in the superficial temporal artery remained elevated in high-capacity bypasses, with the mean difference of 8.13 centimeters per second. Also, end-diastolic velocity in the external carotid arteries was elevated at 3 up to 6 months post-surgery in high-capacity bypasses, with a mean difference of 8.71 centimeters per second. Of course, our study had limitations. So first, there was high heterogeneity in terms of postoperative time points, assessed vessels, and ultrasound parameters reported in all publications. There's also no standardized definition of good bypass patency. Data is coming only from Asian countries, which may limit the generalization of our results to other populations. Additionally, ultrasound is highly operator dependent, which may provide an additional layer of heterogeneity, and also the sample sizes and subgroup sizes were very small in our study. In summary, our findings suggest that there are certain postoperative ultrasound parameters predictive of high bypass capacity following revascularization surgery in moyamoya disease. This modality may offer a valuable tool for postoperative monitoring of patients, especially when the assay is not feasible. However, more standardized multicenter studies are needed to further clarify the clinical relevance of ultrasound in assessing bypass capacity following revascularization surgery. These are the references, and thank you for your attention.
Thank you for your presentation. And because the majority of studies came from Asian centers, I would like to ask, because in one of the limitation you put the information that the data only come from one group of patients, but the disease is predominant in Asia. So I would like to ask if you, in the department clinic you are working or you are doing your research, have you ever had the patient with moyamoya disease?
No, unfortunately we did not, and also I think that because there's very limited number of centers in Europe overall where they perform bypass surgery. So usually, if there is a patient with moyamoya, they are not referred to like our clinics, but they are referred usually to Berlin or Helsinki, or I think there's also one in Italy. So we never had a patient with it.
In case of the diagnostic procedures, if the patient is admitted hospital, he's probably analyzed in the direction of stroke.
Yes. Mm-hmm.
So in some cases, the patient may obtain the drugs that are given after the stroke incident, and may not be well designed, designated as the moyamoya patient.
Yes.
So the question is, based on the results you have had, is there an idea how to encourage doctors in countries in which the moyamoya disease is not very often or is incidental to search for specific pattern of the moyamoya disease?
So,
in personal, for me, this was the first time I've heard about this disease.
Yes, I know, because it's very rare. So I think the only way that we can maybe draw more attention to this disease is by sharing it and being focused maybe a little bit more in research on such cases, and maybe report it more often, because we obviously, if there are not many patients admitted to our clinics with moyamoya disease, we're not able to conduct large studies, right? But even reporting small case reports, I believe it will help, even in our journals, Polish journals, I believe that it would draw more attention, and we can like make conclusions based on these case reports as well. So I would encourage, I think, people to focus on the smaller case reports in our maybe local community, I would say, and this way draw more attention to this kind of patients.
Thank you very much.
Are there any cases of Moja disease in Poland? And if they are, to which clinic they were going? Yes. What will be done?
Actually, I mean, I'm not unfortunately aware if there are cases with Moja admitted to our Polish centers, but actually I believe that Łódź is actually one of better centers in terms of vascular neurosurgery, and I know that it is very, like in terms of research, it is very very encouraged here and is very well performed. So I believe that would be a nice center to admit those patients to.
Okay, and the second question, did you calculate the risk of bias?
Yes, I mean, we did not perform the Eggers test because we have the smaller number of studies, like below 10, but we assessed the funnel plots by visual inspection, and there was unfortunately bias coming from the studies. Yeah.
Okay, thank you.
What about the prevalence of this disease? Change or not in the world, especially in Asia, especially according to this for cases for the younger populations?
Could you
So for the younger population, we have much more cases. So I want to ask, what about the frequency of this disease? Is it stable, passing the years, or this changeable?
I think it changes mainly because we have better diagnostic tools right now to be able to assess and identify this kind of patient. So I think that in the past years, like the incidence may have risen. Yeah. Thank you very much.
Before the next participant, I would like number 11, Zofia Płonkowska, and number 12, Julia Majorczyk, to deliver the presentation. Thank you so much, and we are not stopping. Wojciech Bocheński.
So, good afternoon, my name is Wojciech Bocheński, and today on behalf of my colleagues I am pleased to present you long-term outcomes of ACL reconstruction using quadriceps tendon bone autograft with at least 10 years of follow-up. We have nothing to disclose. So ACL is the most commonly reconstructed ligament of the knee, with the annual number of reconstructions in Poland exceeding 10,000. And with many available grafts for this procedure, the most commonly used are those taken from patellar ligament and from the hamstrings. The bone, patellar tendon bone, gives us the bony healing and faster return to activity. However, the anterior knee problem may be seen in up to 75% of postoperative cases, including patella baja and patellofemoral joint osteoarthritis. What is more, we are more dependent. The graft length can influence the surgical technique. On the other hand, the hamstrings give us the preservation of extensor mechanism with less donor side morbidity. Unfortunately, while harvesting hamstrings, we weaken the ACL agonist, and our graft is less secured. So, and what is more, we are more dependent on the unpredictable diameter of the graft. So, to try to overcome these issues, we started doing the quadriceps tendon bone graft, in which we have a full control over the graft properties, as we can adjust the length and the size of the graft to our preoperative plan, and still have the possibility to harvest the bone block from the patella. And what is more, we can be very reproducible. In almost every case, we can harvest the same length, size, and diameter of the graft. So the aim was to assess the outcomes of the quadriceps tendon bone autograft in anterior cruciate ligament reconstruction after 10 years of follow-up. For that, we checked the rotational stability by pivot shift test. The anterior tibial translation was assessed by Lachman and the rollimeter. We measured the range of the flexion, hyperextension, dynamic hyperextension, and ability to sit on dorsiflexed ankles. And the limb strength and donor side morbidity was also assessed, and functional scales such as COS, IKDC, and satisfaction from the surgery was also included. So every patient was operated in the same way. The transportal technique with the use of quadriceps tendon bone full thickness graft. It was fixed in full extension with 2 interference screw, and it was also augmented on the tibial side with a bone bridge. So speaking about the size of the graft, it's just like in life. It doesn't have to be big, it just has to be long and thick. So this was the post-operative protocol for our patient. And the inclusion criteria was over 10 years of follow-up and isolated QTB, ACL, reconstruction with or without meniscal repair. And 35 patients were included. The mean age was 44 years, and the mean follow-up 11.3 years. The rotational stability was assessed, something bad happened to the video, with a pivot shift test. It was graded as normal in 72% of the joints, and no one had grade 3 pivot. Nobody had more than 2.5 millimeters of side-to-side difference in terms of anterior tibial translation, and the Lachman endpoint was hard in 84%. No endpoint was seen in only 3 patients. It was objectively measured by rollimeter as a difference between the reconstructed and healthy side. And this is the video from the measurement, the rollimeter measurement. And as the difference between means was 0.65, and nobody, as I said, nobody had more than 2.5 millimeters of side-to-side difference, and the most common value for the stability threshold that you can find in the literature is 3 millimeters of difference. We find this finding particularly not clinically significant. So we measured the range of motion with long lever goniometer, and we found no differences between both limbs in terms of flexion. Each one of our patients had the full extension, except one with 16 degrees of extension deficit. Seems pretty good, right? But we went further and we checked the hyperextension, and it was in 32 patients of 36. The difference was less than 5 degrees between both sides. Moreover, the 91% of patients had the ability to dynamic hyperextension, and this is how we checked it. And the satisfaction from the surgery was excellent. The COS score was graded as a very good, and IKD showed very good patient-reported knee function. The muscle strength and donor side morbidity was assessed with certified handheld dynamometer from the Sauter company, and we found no differences in flexion and extension force between both limbs. The donor side was assessed by application of force over the harvest site, and minimal force of 50 newtons was applied and continued pain or discomfort. And of course we found no differences between both limbs. 35 patients were able to do a full squat, and 83% of the patients could sit on their dorsiflexed ankles. Of course, as usual, it's not perfect procedure. We had 2 reters, and 1 traumatic and 1 gradual, and 3 contractures, 1 due to massive osteophyte that you can see in the picture, and 2 arthrofibrosis. So in summary, is a QTB a reliable graft? After 10 years of follow-up, we can say that in terms of stability, yes. Range of motion, yes. The muscle force, yes. And the functional scales and satisfaction, yes, with no donor side morbidity and low complication rates. Thank you for your time and attention. The research is still ongoing, and more up-to-date version will be presented at ISACOS 2025 in Munich, Germany, as a podium presentation. Thank you.
Thank you very much for this presentation. We wanted to have that. Thank you. This is what we were afraid of. Can we go to one of the first slides when you have described the group?
Okay, of course.
Yes.
This or this?
This one. So you you had much more males than females, and the mean age is the mean age of the operation, or the mean age of the follow-up?
No, the mean age is it's the mean age at the follow-up, at the last follow-up.
So they were 10 years younger. Okay, and okay, 37 people included. As a person that was operated with ACL, but not with this kind of graft, I know that one of the most important thing is how the physiotherapy was introduced. So the question is whether they were administered to the sport-like physiotherapy with full force pressure from the first day post-op, or they had like this prolonged procedure in which they were not able to fully step on the foot, not to fully extend or rotate the knee.
Well, I don't know if I understood your question well, but this was our post-operative protocol, and since the first day they had to do the full extension with gravitation, so they placed the leg on the bed and for 5 minutes, and every hour they had to do that. And weight bearing was as tolerated, enabulating, of course, with crutches for the next 14 days. After those 14 days, when the healing response was a bit more silent, they had supervised physiotherapy for the next 3 months. And after that, they had to wear the knee orthosis when going outdoor. And after the 6 months, the sitting on the bent knee was allowed, because during the sitting on the bent knee, the tibia is a bit of subluxating, so we don't really want that to happen after the procedure, because the graft may loosen or something like that.
Were they reoperated to remove the pin from the bone?
No.
No. So this was the pins that are being dissolved in the
No, they are titanium. They are titanium, and they are left in the bones.
Okay, so my question is to draw the conclusion, because you have shown that this technique it's giving good results.
Yeah.
How would you compare this technique with the transplants that were from the biomaterials, not the transplant from the patient's
right now,
tendons?
okay, I know it. Right now, the allografts. Let's go back to one of my first slides. Oh, here the allografts right now are not a standard, not in a standard use. The autografts are the most common use, because we can harvest them during the surgery, and we don't have to just reserve them or get them from a special center. And what is more, allografts are reserved for really complex surgeries when we don't have that much graft, because, I don't know, it was a third ACL tear of the same leg, and we have limited options.
Ligament left.
Yeah, there is no patellar ligament left. Exactly. So in that situation, we would go for the allografts, but it's not a standard.
And from the point of view of the operation, how much longer is to obtain the quadricep tendon in comparison to patellar ligament during the operation? Because
but you mean about the harvest? You mean the harvesting process?
Part, yes.
It's not longer. I spoke with the senior surgeon that did the operations back then, and he said that it's even shorter than because you don't have to, because in patellar tendon bone you have to harvest 2 bones, so you have to cut the 2 bones, then you have to cut the ligament and harvest them. But in this situation you can just take the bone from the patella, and you have only ligament to cut, and that's it. So. And there is a great advantage that this procedure should last, is like shorter, because in the BTB graft sometimes when the graft size is in terms of patella, when we have a patella alta, so the ligament, the patellar ligament is longer than it is as usual, we have to adjust the angle of the tibial tunnel so that the bone block doesn't protrude from the tibia. So we have to adjust that intraoperatively, so it may bring some problems. Yeah.
Thank you. Thank you very much for your
Thank you.
responses.
Thank you so much. I'd like to give the floor to Zofia Płonkowska.
Good afternoon, everyone. My name is Zofia Płonkowska. I'm a biomedicine master student at the Medical University of Lublin. And today I will be presenting our study on locomotor activity, alterations, and embryotoxicity of acetaminophen and its metabolite in zebrafish larvae, which was conducted with my colleague Maria Zabaj under supervision of Łukasz Kurach. And why we decided to even test acetaminophen, also known as paracetamol. In general, it's when it comes to over-the-counter drugs, it's most used analgesic drug, and because of its low-cost availability and safety. And what is important, acetaminophen and its metabolite para-aminophenol can easily cross the blood-brain barrier and the placenta. And the analgesic effect is made mainly in the brain. So paracetamol itself has a lot of different mechanisms of action through different pathways, and also its active metabolite AM404 also contribute to analgesic effect and has even different mechanism pathways. So the question is paracetamol safe in pregnancy? So in general, acetaminophen is a drug of choice for pregnant women, and it's in general considered safe. But there is a rising number of research papers reporting the potential associations between acetaminophen taking acetaminophen during the pregnancy and abnormalities in children, like genital malformations, ADHD, autism, or even early puberty onset. So the aim of our study was to test the toxicity and developmental abnormalities and behavioral effects of acetaminophen and its metabolite in early vertebrate development using zebrafish embryos. So embryos were divided into groups, the negative control group with E3 medium, and treatment groups, 6 different concentrations of acetaminophen and 7 different concentrations of para-aminophenol. And we started with fish embryo acute toxicity test, following the OECD protocol. So first day, we prepared the fresh solutions and put embryos in a 6-well plate with proper concentrations. And every 24 hours, we were looking for developmental abnormalities. And at 96 hours post-fertilizations, last observations were made. We counted heartbeats and assessed the behavioral effects through light-dark transition tests using special equipment. So basically, computer counted the total distance traveled of every larvae for 10 minutes in the light and then 10 minutes in the dark. And going to the results. First, we calculated the median lethal concentrations for both of the substances. And for acetaminophen, it was roughly 6.5 millimolar concentration. And for para-aminophenol, it was 2.5 micromolar concentration. And when it comes to developmental abnormalities in acetaminophen-treated embryos, we observed pericardial edema, blood accumulation, and abnormal tail curve in a dose-dependent manner. And also reduced pigmentation in the body in all treated groups, and reduced pigmentation in the eyes in almost all groups except of the lowest tested concentration. And the cardiotoxic effect of acetaminophen was present in the two highest concentration, where the heartbeat was significantly lower than in the control group. And the effects of acetaminophen of locomotor activity. Normally, zebrafish larvae are more active in the dark conditions. In the locomotor activity in the light was reduced in the two highest concentrations of acetaminophen, and in almost all groups of acetaminophen in the dark. And what is more, you can see that two highest doses of acetaminophen caused like the differences between the light and the dark is very low, and this lack of change between the behavior of larvae in dark and the light indicates the neurotoxicity, sedation, and impaired reaction to this change of conditions. And none of those observations were made when it comes to para-aminophenol. So to conclude, acetaminophen induces developmental and behavioral toxicity in zebrafish embryos in a dose-dependent manner. And even though para-aminophenol appeared less toxic, its highest dose was lethal, indicating a narrow safety margin. And these results add to a rising number of papers questioning the safety of use of acetaminophen in pregnant women. And thank you for your attention. I'm happy to answer any questions.
Thank you for your presentation. So I have a question. Why did you choose a zebrafish for your experiment?
So when it comes to toxicology studies, I think it's a very good model organism because it's a vertebrate, and because of ethical causes, until fifth day, embryos and larvae are not considered animals. Therefore, we don't need to ask for ethical permission, so it's easier to do and more ethical, I think.
Thank you very much.
I would like to ask about the concentrations, because the highest concentrations that you were testing how they can be compared to the concentration of the paracetamol in the blood.
So I'm gonna go back to here. So the median lethal concentration, 6.5 millimolar, can be like with the simple calculations, not like any advanced pharmacology, compared to taking daily dose all at once. So 4 milligrams of acetaminophen at once.
You observe concentration of this substance in the blood, but in the blood, yeah. But it's possible there is also increased concentration and accumulations, yeah. Because I think about accumulation in other tissues, and if in which one especially, maybe you know.
Accumulation of acetaminophen.
Yeah.
Of course, liver, because it's it metabolizes it, and also brain, because it can cross the blood-brain barrier, so it can also accumulate in the brain, I think.
How would you compare the toxicity of acetaminophen and ibuprofen? Because for small children, newborns, ibuprofen is recommended.
I don't have like any informations about ibuprofen toxicity, not in the zebrafish. I don't know anything about it, so it's hard for me to compare it. Maybe I think that would be my next step, to compare those toxic effects with different analgesic drugs.
Yes, it would be interesting. One more question, because in relation to what Dr. Khalid asked about the concentration in tissues, you have checked the concentration in tissues in the larva after the experiment?
No.
No. So those results are the results from the general results from the administration of acetaminophen in humans, when we were asking about the concentration in tissues, in organs. So you did not compare the concentration of the metabolites in the tissues of the zebrafish after the experiment?
No, I didn't.
Okay, but it could be done?
I think it could be done somehow.
Yeah.
I think we can take the fish, just homogenize it and try to...
Maybe not entire fish, maybe first the section to obtain the tissues. And then, because it would be very interesting, because in order to draw the conclusions to use it against the usage of the drug in pregnant women, or to raise awareness, we need to have more information regarding in which tissue of the developing body it will accumulate the most, because you have showed here the results of the physiological analysis of the movement and the reaction. However, there's like another layer of information where the metabolites are stored.
Yes, I think it's a very interesting next step. And when it comes to fish, it's hard to make such advanced analysis of selected tissues, because fish are very small. So it's hard to separate the tissues. Maybe all organs we can start.
Yes, I was thinking maybe more about the organs than the tissue, but yes, this is what I meant. Thank you very much.
Thank you very much.
I invite Julia Majorczyk.
Respected members of the jury and dear colleagues, my name is Julia. I'm a fourth-year dental student at Medical University of Łódź, and I appreciate the opportunity to talk about my research that I conducted together with Dr. Agata Szczesio-Włodarczyk and Associated Professor Kinga Bociąg. The study focuses on analysis of selected mechanical properties of gingiva colored resin-based composites imitating soft tissues. So here's a brief outline of my presentation for today. First, gingiva colored composites are used by dentists to restore cavities around the neck of the tooth, so to imitate the gums, especially in the anterior area, where aesthetic results are very important for the patient. So in case of class 5 restorations with gum recession, also in root cavities, as the same as non-carious cervical lesions, such as abrasive defects as a result of aggressive toothbrushing. And I know that gum recession should be treated surgically by covering the recession with connective tissue. However, the surgery involves expensive costs and time to heal for the patient. So this is an alternative, more provisional, conservative solution in case when the costs are a concern for the patient, or in case the general health of the patient is in a bad condition, or for example in non-cooperative patient. Also, some dentists use pink opackers to cover the discolorations before placing a veneer or standard composite filling. So these are the shades of the composites that can be used, so the doctor is able to select the most appropriate one for the patient. At the bottom there is, at the left picture, we can see that if we fill the tooth with the standard white composite, the teeth may look elongated. However, on the right picture, the composites may not even be noticed at the first glance for a non-professionalist. Here are more clinical cases. At the bottom there are some abrasive defects and filled with these composites, and at the right picture there is a pink opacker used as to mark the discolorations and to eliminate the grayish shade of the teeth. So the aim of the study was to evaluate basic mechanical properties of these composites, because there is a research gap investigating whether the pigments that are added into the composites affect their durability and mechanical properties. So these are the composites I've tested so far. First three composites are pasty-like materials, and the Arcona flow is flowable material. All samples were prepared according to ISO norm 4049, so were polymerized and then held in water to imitate oral cavity condition. So to determine 3-point bending strength and elastic modulus in bending, 6 samples were inserted into the testing machine, which applied a constant force in the middle of the sample, and the sample on the opposite side had 2 support points, as in the diagram. Diametral tensile strength is a special way of testing the tensile strength in materials that are brittle. So in case of composites, dental composites, and the sample was subjected to compression until the damage of the sample. Hardness was investigated by was investigated by Vickers method. So the diamond intender was pressed into the surface, and then I was able, in optical magnification, to measure the 2 line segments and plug them into the equation. So this is the list of the composites I tested and their composition. I emphasized the amount of filler, the filler particle size, and also the monomers that were used, because they all affect mechanical properties. And also I would like to emphasize that a beautiful gingiva has surface pre-reacted galaxionomer technology. That means that this composite can release and also absorb fluoride from the mouth, so it has more biocompatible effects on the tissues. When it comes to results, hardness determines the resistance of the material to fracture and also its wear resistance. So the Filtek Universal Pinko Packer has the highest results. Bending strength determines the maximum pressure that the material can handle without being damaged, and also Filtek has the highest results. And surprisingly, the flow color, which is a flowable material, has higher results than the other two composites. Elastic modulus determines the rigidity of the material, and also Filtek has the highest results. However, these results are similar. And also Filtek has the highest diametral tensile strength. So taking all of this into the consideration, so the results and also the composite composition, some conclusions may be drawn. First of all, more inorganic filler loading results in better resistance to tensile and bending and higher hardness. Nanohybrid composites has lower durability than microhybrid ones. However, in this situation, I would recommend to use nanohybrid composites because the occlusal forces at the anterior teeth aren't that high, so it's not that important. But nanohybrid composites can be well polished, so it's better in the anterior area. Also, monomers influence mechanical properties. So, for example, Filtek has special low shrinkage monomers that enhance its properties. And in general, mechanical properties of composites are associated with the type of the material. So is it a flow or a pasty-like material, the amount and size of fillers particles, and the monomers. And what is important that these results can be comparable with any other standard tooth-like composites with similar composition. And as I said before, there's a research gap in this topic, and the only article I found about mechanical properties was the first one, and the rest of them is completely different topic. However, there's still a few articles about this topic, and our future plan for a study is to investigate more composites to have a bigger view, and also maybe estimate the water resorption or color stability in aging processes. And thank you for your attention.
I would like to ask about resistance to microorganisms, because in oral cavity we've got a lot of bacteria, sometimes fungi. If such material are resistant to adhesion of microorganisms and forming biofilm.
Okay, I know that filling around gum line can be controversial. However, if we choose nanohybrid composite, as I said, they gain better results in polishing, so the smoothen the surface. So the plaque stagnation area is worse than in the microhybrid ones, for example. Also, if there is no overhanging of the filling or the patient take care of the hygiene, so floss daily, this is the prevention before inflammation. As also, as I said, this can be a provisional solution. The gold standard for treatment gum recession is covering the recession.
But for these four types of material, were such experiments made? Were they checked if they are
about bacteria stagnation?
Yes,
no, I
biofilm.
haven't found any. But maybe it's an idea for the next study.
Yes, my scientific students club can help you with that.
Okay, thank you.
I have a question. This material is stable, yeah, but how long we can stay with them? Should they change it after some time? Think about the patients.
I think it's like a standard composite. It depends on the doctor. It depends on if the area were dry before placing the filling. So the normal standard composites last 5 years, 10 years maybe. However, I didn't find any articles about that because I think that maybe it's more used for waiting while for the surgery or something, because I didn't find any long-lasting results.
I have the question regarding the use of this material, because if we are applying something in the upper part of the tooth and we have the problem of the recessive gums, is it acting acting, is it acting like it's even making the recessive gums to move even further? Because we still have, in the place where the gum should be present, we are putting a composite, and while cleaning while brushing the teeth and flossing, we can even make the recession of the gum even further.
I think that by flossing and not allowing bacteria to grow, the recession will not advance. Yes.
So the last question. What type of statistical you use for this research?
It's just the beginning of the study, so we don't have any statistics yet, because we plan to investigate more composites, so it will be done, but not right now.
Thank you.
Thank you.
Thank you very much. I'd like to give the floor to Maja Czerniachowska.
Maybe I could try speaking like this then. Hello, dear ladies and gentlemen, dear jury and students. Today I would like to talk to you about endometriosis, which is one of the biggest struggles of young women these days, and the possible culprit, an anaerobic species of gram-negative bacteria, Fusobacterium. As you can see here, and I'm sure as you've heard already, endometriosis is a disease characterized by a benign growth, benign proliferation of endometrium-like tissue, most commonly found in the ovaries, peritoneum, and other locations in the abdominal cavity. It is said that 10 to 15% of women suffer from it, and given its challenging diagnostics, it makes it a significant clinical problem. A study by Japanese researchers published in 2023 suggested that Fusobacterium species, a part of natural human microbiota, facilitates development of endometriosis through TGF-beta activation. According to the study, 64% of women suffering from endometriosis were found to have the bacteria in their endometrial tissue, while it was only 10% in the general population. So we decided to do a little version of that experiment here in Poland, together with the gynecological oncology and endometriosis treatment clinic in Polish Mother Institute and our CKD's Department of Microbiology. The question we wanted to answer was, as you can see here, is there a correlation between the presence of Fusobacterium and the presence of endometriosis? And for that, we divided our group of 12 patients into two groups, 5 suffering from endometriosis and 7 who underwent hysterectomy for other reasons. Each of the patients, of course, was scheduled for either a surgery as a treatment of endometriosis or hysterectomy for other reasons. Each of them gave us an informed consent for the participation in the study. And then from each of the patients, we have collected 4 samples. Prior to surgery, we took the oral swabs as well as the cervical swabs, and during surgery, peritoneal fluid and cyst wall samples. And here is what we did to each of them. The oral samples were stored in amnios transport medium and then cultured in appropriate agar and broth mediums and incubated. The cervical as well as the peritoneal fluid samples were frozen at -20°C and afterwards incubated in anaerobic conditions. And the cyst wall sample collected was put into a sterile container and then afterwards incubated. Each of the samples were both cultured and incubated in anaerobic conditions, and that is to ensure an appropriate environment for the bacteria, who, I'd like to remind you, is obligatory anaerobic. And here is what happened to the samples next. Then we took each of them, and they underwent PCR analysis using the following studies here, and the microbiological analysis using Schedler anaerobe broth and Schedler anaerobe broth with sheep blood, popularly called blood agar. Then we incubated them for 48 hours in 36 degrees Celsius. And then each of the distinct colonies were isolated and cultured again using the blood agar and identified using multi-time of flight Vitek MS. And the results were as following. In the research and the control group, the Fusobacterium was detected in oral swab samples, in PCR, in 4 out of 5 and 6 out of 7 cases, respectively. So in the majority of them. However, no Fusobacterium species were detected in the colonies in any other samples, and the PCR analysis of any samples other than the oral swabs mentioned above also yielded negative results. So the conclusions, the first one, I'm sure, as true in many other types of research, would be we need more patients and we need a bigger, larger group to analyze that, because right now the results are pretty inconclusive. However, these results made me think. I was lucky enough to, as a student, be a part of the ER one day, and I was observing the procedure of collecting the samples, and I couldn't help but wonder, could the surgical methods themselves, and especially the cauterization used to cut the tissues and the rising temperature, could they be responsible for the negative colony results? And also, in the future, maybe, could antibiotics prove to be an effective treatment of endometriosis, analogically to the stomach ulcers in H. pylori? I think that's a very interesting perspective. These are the questions I had for you, dear viewers, and here are the sources. Thank you so much for your attention, and if you have any questions for me this time, I'll be very happy to answer them. Thank you.
Could you go back to methodology?
Yeah? Which one?
Here, yes.
Yeah.
Why you don't have swabs from vagina and cervix into microbiology checked, into medium? Over here you've got only sterile tube with no medium frozen, so no culture?
Oh, no. Each of the samples are cultured, all of them. Yeah.
Okay.
Just the different methods have to be used because of the type of, the type of tissues we use.
Okay, because from the slide it's not clear. Okay, my other question, other group of microorganisms which could be connected with endometriosis. Is there any, only Fusobacterium?
Well, right now they are researched the most, and they have the biggest. While looking at research and the literature, Fusobacterium is the main culprit that is suspected of causing these kind of changes, because the huge study by the Japanese researchers Moroka in Nagoya University was very big news back in 2023. It was a very multi-dimensional study, both on cultures, both microbiological on patients using mice in vitro and cell cultures. It proved to actually, for example, maybe I could would describe one of the experiments that really stuck with me. The mice were actually infected with Fusobacterium at some point, and then turns out that when the bacteria was delivered transvaginally, some of them a huge amount of them developed endometriosis in the end. So yeah, based on the studies that are happening recently, that is the main culprit. But of course, we can't say that for sure because we always could use more research, and also, as many other diseases, it is believed to be multifactorial. So that is one of the possible ideas.
Okay, and does in some literature, maybe some hypothesis from where in cervix, in vagina, there are fusobacterium. Fusobacterium are typical in oral cavity. So is it maybe, I don't know, translocation or blood-related transport, something like that? Because fusobacterium is also responsible for intestine
yeah, right,
tumors.
right.
So over there it's easy, but
yeah, right,
here
right,
it's a little different.
right. That's correct. Fusobacterium is mainly used in the oral cavity. That's why we used also oral swab samples. And mainly the literature mentions that it could be a blood-borne transmission.
Can we go to the slide where you were discussing where from you were doing the PCRs? Because you have extracted DNA from the swabs. Maybe this was in the results.
Should I?
Yes, yes, please.
Yeah.
And yes, so you have extracted DNAs from cervical swabs, the peritoneal fluid, and endometrial cyst walls.
Yeah.
And there was no fusobacterium detected.
Yeah, there was no fusobacterium DNA detected.
Okay, but maybe you should use more sensitive method, or maybe if you could go for the NGS testing, especially if you would do the 16S RNA sequencing. Maybe in this study you will see whether there was fusobacterium and how much it was there.
Yeah, exactly. That's what we were actually, right now we wanted to stick to PCR since it's more readily available, and also, of course, that's also a main issue. And also because the original study used that, so we wanted, wanting to be we just wanted to, change the population pretty much. So the PCR was the easiest option, but definitely seeing those results, I think NGS would be the best option.
Okay, so maybe look for more different starters, more different primers, because maybe this will be the option to find the presence of fusobacterium or other type.
Yeah, that's what we are considering as well. That's it. Thank you so much.
Thank you very much. I'd like to invite Monika Reszka.
Okay, so good afternoon everyone, dear jury, dear participants. It is a privilege to stand before you today to discuss a pressing issue of the prenatal cardiology. My name is Monika Reszka. I'm a first-year obstetric student here at the Medical University of Łódź. I'm also the member of the Presidium of the National Student Scientific Circle of Prenatal Cardiology and a member of the Student Scientific Circle of Prenatal Cardiology. So the question I sought to answer today is both simple and profound. Does the maternal BMI influence the incidence of the fetal heart defect? So the implication of these questions exists far beyond the academic, curiosity. It touches the clinical practice, the public health, and the future of prenatal care. So let's dive into the data, explore the mechanisms, and discuss what this means for the patients. Okay. So to understand the significance of my study, we must first recognize the broader landscape. So globally, obesity has reached epidemic proportions. The World Health Organization reports that 650 million adults are obese, with maternal obesity rates in Europe ranging from 10 to 40. In Poland, the situation currently is 23.22%. And I would like to also mention that it has increased by 58% since 2010. At the same time, the congenital heart defects, the CHD, remain one of the most common birth defects, affecting 1.35 million newborns annually. So in Poland, the prevalence of CHD is 9.7 per 1,000 live births. Meanwhile, in Europe, is 8.2 per 1,000. So as we can see, it's higher than the average in the whole Europe. So this statistic paints a clear picture that obesity is not just a metabolic disorder, it's a potential teratogen that shaping the fetal development in ways we are only beginning to understand. So, I'm sorry. Can I get help? It doesn't work. Okay, so now it's time for the study aim and the hypothesis. So with the context in mind, my study had two primary objectives. So the first one was to quantify the association between the BMI and the fetal CHD, adjusting for confounding factors such as gestational diabetes, smoking, and chronic hypertension. Second, I thought to, of course, characterize the types of CHD most prevalent in obese mothers and identify the risk BMI thresholds for targeting screening. So my hypothesis was that obesity, the BMI above 30, independently increases the CHD risks, and that the metabolic dysregulations mediates. Okay. So the next one. Methodology. So the study leveraged from ICZMP, the Mother's Child Institute, the prenatal cardiology clinic database, comparing 1,359 pregnant women. In the final cohort, there were 179 pregnancies, 176 singleton, and 3 twins. And as you can see, there was exclusion criteria. There were the twin pregnancies. And statistical methodology, the chi-square tests. Okay, so the next one, the maternal and the demographics and comorbidities. As you can see here, we have the table that shows the height and the kilograms and how does the BMI looks. And now, from my study, the key demographics, that the mean maternal age was 32.1 years old. And we also had the 28% of women classified as advanced material age. It was above 35 years old. Also, the BMI distribution revealed 13% of obesity, so it was the BMI above 30. Also, we have the category of overweight, normal weight, and underweight. And the comorbidities were prevalent in the obese group, including gestational diabetes, it was 19.3%, the chronic hypertension, 24%, and the thyroid disorders, 31%. Okay, so now the types of the congenital heart defects. So in the obese cohort, which was above 30, 38% of fetuses were diagnosed with the CHD. So the most common anomaly was the ventricular subdefect, accounting for 37 cases. However, I also observed severe and complex defects such as tetralogy of Fallot, single ventricle, transposition of the great arteries, or hypoplastic left heart syndrome. Okay, I also wanted to show you the example of the tetralogy of Fallot in an obese mother. So the patient was Paula P., age 33, BMI 29.4. The clinical history was GDM, polyhydramnosis, and the fetal diagnosis was DiGeorge syndrome, the tetralogy of Fallot, and the MAPCAS. And the delivery and neonatal data was the vaginal delivery with the birth weight of 3,060 grams, and the Apgar was 9 out of 9 in the first and the 5th minute. And the outcome, unfortunately, it was neonatal death at the 3 days due to cardiac failure. Okay, so now the obesity and CHD risk. So my analysis revealed that obese mother had 2.3 times higher odds of fetal CHD compared to mothers with normal BMI. However, when we adjusted for for diabetes, the odds ratio dropped to 1.8, indicating that metabolic disturbances like hyperglycemia explain part but not all of the risk. So these findings underscore that obesity is an independent risk factor, but its synergy with conditions like GDM creates a perfect storm for cardiac maldevelopment. Now, the pathophysiological pathways. So how exactly does the maternal obesity translate into the fatal heart defects? My review of the literature points 3 key mechanisms. The first one was the hyperglycemia and the hyperinsulinemia. It's the excess glucose and insulin disrupt neutral crest cell migration. So this explains the higher incidence of tetralogy of Fallot, for example, or the transposition of the great arteries. Also, it was the chronic inflammation and the oxidative stress. So the reactive oxygen species accumulate in the fetal heart, causing the DNA damage and the cardiomyocyte dysfunction. So clinical implications. So my findings demand a paradigm shift in the prenatal care. Here's what I propose. So first, we need to focus on the preconception interventions. We should referral to weight management clinics for women with BMI above 30. And also, we should propose the high-dose folic acid paired with myo-inositol to mitigate the insulin resistance. On the second hand, we should enhance the screening protocol. So the fetal echocardiography from 18 to 22 weeks, of course, for the obese mother, with the repeat scans at 28 weeks if needed. And we should, of course, continue to glucose monitoring to detect early gestational diabetes, a modifiable risk factor. Also, the public health measures, which I think are also quite important in this case. So the national guidelines for women with BMI above 30 with specified CHD screening, community campaigns promoting preconception weight loss and metabolic health. So I think by adopting these strategies, we can disrupt the obesity CHD cascade and improve outcomes for mothers and the babies. Of course, we should also talk about the limitations. While my study provided compelling evidence, it's not without limitations. The sample size was 166 obese pregnancies, restricted subgroup analysis for rare complex CHD. Also, we have unmeasured co-founders such as diet, paternal BMI, epigenetic, and the future work that I think we should focus on was to multi-center the prospective studies to validate our findings, of course. Omic approaches to identify novel biomarkers and therapeutic targets. So this work is just the beginning of the way. So collaborating across disciplines will be key to unrevealing the full picture. And conclusion and a call to action. In closing, my study demonstrates that maternal obesity is an independent risk factor for fetal CHD, with metabolic comorbidities amplifying this effect. The message is clear. Obesity is not just a maternal health issue, it is a fatal cardiac risk factor requiring urgent attention. So together we can transform this insight into tangible strategies to protect the smallest heart among us. So thank you very much for your time and engagement. I welcome your questions and thoughts.
Yes, I wanted to ask, because you have mentioned some severe cardiovascular cardiac malformations.
Yes.
And some of them were related, some of them are not related with genetic disorders. for example, as far as I'm concerned, the tetralogy of Fallot and the single ventricle, they can be multifactorial, and there are no single factor that is leading to the
that's
diseases.
true.
But you have also mentioned the patient with the child that had the DiGeorge syndrome.
Yes.
Would it be right to exclude those pregnancies in which there was an important genetic disorder that may also lead to the congenital heart defect from the overall analysis and statistics?
Well, I thought that including them was a good way to show that they also were in the group, because I focused mainly on the women with the BMI above 30, but I thought it would be a good idea to also show that it exists, it's happening here, and it would be a good thing to point out in this presentation. So.
Yeah, because you have underlined that obesity in women can be treated as an individual risk factor for developing the congenital heart defects.
Okay.
However, in order to rise up this issue, probably you should focus more on making the group more similar, to look for similarities, or to analyze deeply the diet, or regarding the BMI, not only the BMI, but also, as it was mentioned in one of the previous presentations, the body composition.
Okay, sure.
Yeah.
Well,
when we're talking about BMI over 30, there is usually a lot of there is a problem with excessive fat mass. However, still there might be women with high muscle
yes,
percentage.
you're correct. Yes.
And have you considered performing more thoughtful survey with more questions regarding the diet, the sport activity?
Yes, I thought about, of course, continuing this study, because it was data from 2023 and 2024 when I wasn't even here at the university, so it was the data from the clinic. But of course, I thought that it's a good idea to continue it and also do the survey exactly with the diet and how exactly it looks, because here we've had, of course, the data with the weight and how everything looks, but not exactly questions about the nutrition, for example, or stuff like that. So yes, I would like to continue that and develop that topic more.
And I think it would be also good if you could have an access to more to the data from the blood analysis to check whether the level of the cholesterol can vary among the to analyze in groups depending on the hypercholesterolemia or the normal cholesterol level, as well as analysis of the insulin resistance.
Okay, I will take it under the consideration.
Maybe I missed this information, but what is the percentage or probability, I don't know, some congenital heart defects in non-obese women?
Okay, here. Wait. Well, I have this. We mainly focus on the obese women, so it was the criteria actually for choosing.
Yes, I know, but I mean as a form of control, as checking if some heart disease in children in fetal situation maybe increase because of changing of our environment. So maybe also it could increase in non-obese women. So it's as a form of control. You focus on obese women, but also as a control you showed how it looks in the full population and what is the difference. Is it more common or less common?
Okay. Thank you. Okay, thank you very much.
Thank you very much. Last but not least, I'd like to invite Katarzyna
Thank you for your invitation. I have a great pleasure to present a clinical analysis, efficacy and safety of intravascular lithotripsy in the treatment of calcified coronary lesions, insights from a real-world cohort. Calcification is one of the major challenges in percutaneous coronary interventions because of stent underexpansion and for this reason increased risk of instant restenosis or thrombosis. For debulking calcified lesion, we use several methods, such as cutting balloons, rotational, orbital or laser atherectomy, and intracoronary lithotripsy, which is point of interest in our analysis. We have to know that PCI of calcified lesion is a very complex procedure and can increase peri-procedural risk. Intravascular lithotripsy uses shockwave balloon. This is a special balloon with acoustic transmitter inside, produces high-energy acoustic waves that create fractures of calcified lesion like cracking. Early studies show that IVL improves procedural success rates with favorable initial angiographic and clinical outcomes. How shockwave balloon work? We can see homogeneous calcified lesion, which high-energy acoustic waves make it cracking into small pieces. So, not fully expanded balloon after IVL can properly expand it. Aim of our study is evaluation of the safety and efficacy of IVL-assisted PCI in a real-life population with a subgroup analysis of acute myocardial infarction patients. For 4 years period, we analyzed consecutive 201 patients after IVL-assisted PCI using shockwave balloon. The average follow-up was 557 days. We divided the real-life population into two groups. Group 1 with 76 myocardial infarction patients and Group 2 with 125 non-MI patients. Clinical characteristics were very similar in both groups. They didn't differ significantly, and the only exception was heart failure, which occurred obviously more often in myocardial infarction Group 1. In MI Group 1, about 68% was NSTEMI and 32% was STEMI. Syntax score was not significantly higher in MI Group 1. Syntax score is a scale to describe anatomical complexity. The more lesion, the more complex lesion, the higher syntax score. Ejection fraction was obviously lower in MI Group 1. In MI Group 1 was higher incidence of prior myocardial infarction history, opposite to Group 2. And in MI Group 1, there was more often prior PCI of right coronary artery. Prior bypass surgery didn't differ between these two groups. S2 vessel treated, LAD, LCX, RCA, were treated similar by lithotripsy, and only left main was treated significantly more often in MI Group 1. Characteristics of treated calcified lesion didn't differ between these groups. Procedure success was nearly 100% total and in both groups. IVL success was also very high, more than 97% in all groups. Drug-eluting stent and drug-coated balloon were used in similar quantity and percentage in all groups. Radiation dose and contrast volume didn't differ between these groups. IVUS or OCT were used in more than 50% in all groups. Non-MI Group 2 was treated significantly more often with clopidogrel and MI Group 1 with ticagrelor. S2 in hospital outcomes, MI after PCI, in hospital death, and contrast-induced nephropathy, they were very low and similar in all groups. Comparison of MI Group 1 and non-MI Group 2 MACE, which included death, stroke, or myocardial infarction, didn't differ, and the same for all-cause mortality, myocardial infarction, and cardiovascular hospitalizations. Follow-up analysis of our total group revealed some independent predictors of all-cause mortality after IVL-assisted PCI, such as chronic kidney disease, post-rotablation debulking, prior CABG, and long lesion length, which match the literature. This is an example of IVL PCI. This is a 73-year-old female patient with history of unsuccessful rotational atherectomy 4 months ago. We can see RCA mid-lesion 80% with severe calcification proved in IVUS. Then we can see shockwave balloon 3.0 under expansion, and then after IVL, balloon fully expanded. Then we can see successful stent implantation 4.0/12 and excellent final result. Conclusions. IVL is an effective treatment of calcified atherosclerotic lesions, delivering excellent success rate in all treated patients, including those with acute myocardial infarction. IVL is a safe option with low peri-procedural complication rates in a broad, complex anatomical context. Thank you for your attention.
One question, did you take part in performing the procedures, or you did perform the procedures, or have you had the chance to perform, for example, the post procedures when you were observing the effect with the contrast?
I didn't take part in procedure because I'm only a student, but I saw some procedures, and I also took part in hospital observation of patients. I saw, the patients in the department where they were there.
And from the patient perspective, if you have a chance to talk with the patients, where the procedure was more complicated, or they have to be more days in the hospital after this procedure than other procedures that could be performed in their case. Is the shift change regarding the time in the hospital?
No, actually no. It was similar to other PCI procedures.
Are any recommendation to this exactly to this procedure and to another? Another one. Routine. Is there any predisposition, that this procedure should be performed or not other one?
You mean like recommendations?
Yeah.
So it is actually kind of new technique. It is not that popular. So it is more common to do atherectomy, which is a more traditional approach. But in this IVL, well, there is no strict criteria like where there is lesion which look like that. So we have to do IVL. It is like more fluent criteria or recommendations. Like for example, if in IVUS there is a calcific angle of 270 degrees, then there's some recommendation to do this IVL. It is not like strict criteria.
Are there any risks which can shows up in patients later after this procedure? Any problems? I'm not saying that there were problems in your patients in your clinic, but generally from literature from all over the world where there is similar procedure taken. So were there any problems in patients? Risks? Decrease of their state?
It is,
maybe?
yes. It is intracoronary procedure, so there are always risks, like for example, dissection of the vessel. But we see that the IVL success and procedure success is very, very high. So they're not that common to have complications. Yes.
Okay, so did you consider or include the gender differences in your?
Yes. They didn't differ in statistics, but we do, we did divide the patients into female and male, yes.
Okay.
Sorry. And it was on the table, yes, on the presentation.
Okay, thank you.
So we would say that this procedure is safe and should be more and more popular.
Yes, I will say that.
Okay, great. Thank you very much.
Okay, thank you.
So it was the last presentation for today. Ladies and gentlemen, we'd like to thank you very much for your participation. Now it's time for the jury's deliberations, after which we will provide you with the results of the session. See you in a few minutes.
think we are ready to announce the... You are ready to announce the results. Pan korektor?
Panie profesor. Tak.
No dobrze, tylko to najpierw jest distinction. Najpierw wyróżnienie, więc najpierw nie wręczamy tego.
Dobrze, to najpierw wymieniliśmy. Tak, ta wersja.
No? Tak, tak.
Na ściance potrzebujemy.
Tak, no
Przesuniemy może jest problem.
Gdzie?
No bo to będzie źle rozgrywać. Nie będzie może no właśnie, ja się też tak wydaje, no no.
Tutaj z tej strony, tak? O, super.
No. Tam nawet może być. Dobrze, teraz jest pięknie.
Okay, so we are ready and we want to start with the distinction. And the first person is Monika Raszka. Big applause. And the prize for distinction is the scraps that you can choose from our sponsors in front of the Aula Zachodnia. Gratuluję i oczywiście. Oczywiście potem. Sobie wybrać nagrodę, która stoi przed aulą, a dyplom wyślemy do Ciebie. Dziękujemy Ci bardzo. Okay, and the winners. Let's start with the third place. And the third place is Zofia Piątkowska. Bardzo miło, że przyjechałaś. Now it's time for the second place. And the name of the second place is Rami Altabor. I think Rami is absent because he has got exam, so we'll send the...
Czyli mu przekażemy, bo on jest na egzaminach.
And the first place. And the winner of Juvenes Pro Medicina 2025 is Maja Czerniachowska.
Dziękuję bardzo.
Gratulacje.
Dziękuję bardzo. Róbcie dużo.
Dziękuję bardzo.
Dziękuję bardzo.
To wszystko. Wszystkie nagrody rozdane.
Tak, mogę powiedzieć. Z tego miejsca chciałabym bardzo podziękować oczywiście naszemu uniwersytetowi, że pozwala w ogóle studentom takie badania przeprowadzać, bo to na pewno nie w wielu miejscach jest taka możliwość. Niestety nie jest obecna moja opiekunka ITS, ale też chciałabym jej bardzo podziękować. Pani doktor Agnieszka Kierszewska-Jesionek. Bardzo dziękuję. Pani profesor Pastuszek-Lewandowska. Również bardzo dziękuję. Pani dziekan Braunceis. Fantastyczny zakład i cała Matka Polka też naprawdę świetna współpraca. I jurorom oczywiście bardzo dziękuję, wszystkim słuchaczom. No i dziękuję bardzo.
Dobrze. Proszę Państwa, w ogóle tak, chcielibyśmy może poprosić wszystkich, którzy dzisiaj się prezentowali, do przyjścia i do wspólnego zdjęcia. I chcieliśmy powiedzieć, że bardzo dziękujemy za bardzo wysoki poziom prezentacji, za bardzo ciekawe badania, które też były dla nas wyzwaniem, szczególnie kiedy widzieliśmy Wasze prezentacje po raz pierwszy, więc musieliśmy na szybko złapać, czego dotyczą, jakie metody badawcze stosowaliście, jaka była Wasza rola w tych badaniach, co też jest dla nas bardzo ważne. Więc dziękujemy Wam bardzo za ten wysiłek włożony, za te prezentacje i zapraszamy Was do wspólnego zdjęcia. I przepraszamy, że mogliśmy tylko trzy prace i jedno wyróżnienie. Bardzo nam przykro. Ale to zasady, które nie my ustalaliśmy.